Yeah. Okay. Hello, everyone. Good evening, judges. Am I
Hello.
audible?
Yes, very well audible. Good evening, everyone.
Yeah. Hello, participants. First of all, many congratulations for coming this far and making it to the finals of the national level quiz competition EXCUIZITE, which was which is
Hello.
hello. You can hear me? Hello. Hello.
Are we audible?
Yes, you are. You are audible.
Yes, no.
Okay. Sorry. Yeah, okay. We are having network issues. Sorry. Okay. Congratulations, participants, for making this far to the finals of a national level quiz competition, EXCUIZITE, which was presented by AMSA India in association with Clinic Case and sponsored by Marrow. So now we will be having an introduction to our judges. We are having two judges here, Rupali ma'am and Archana ma'am. Avantika will be introducing them. So ma'am, can you please switch on your cameras?
Yes,
Ma'am,
I've already done that.
Rupali ma'am.
Yeah, I've already switched on my camera. Well, I can see my video.
Okay, Archana ma'am. Archana ma'am?
Yeah.
Okay. Yeah.
Thank you, ma'am. Ma'am, I'm Avantika Singh. I'm the co-organizer with Nausheen of the event Exquisite. So we'll start with your introductions. First, I'll be going with Rupali ma'am. Dr. Rupali Malik. She's the MD Medicine, Associate Professor of Medicine Department, VMMC and Safdarjung Hospital. She's a nodal officer of ART Center. She has her clinical interest is mainly in infectious disease and rheumatology. Rupali ma'am.
Yes, for this event, and I think it will benefit all the students as well as faculty who is involved in the process of this quiz. So thank you so much for inviting and considering and taking this initiative forward.
Thank you, ma'am, for joining us. Uh, we have Dr. Archana Bhate. She's a professor in medicine at Dr. D.Y. Patil Medical College, Nerul. Her clinical interest is mainly in hypertension and diabetes management, and also in infectious disease. Archana, ma'am.
Thank you. All the best to all the participants.
Thank you, ma'am. And the moderator for today's event is Shreya. Shreya, over to you.
Yeah.
Yes, hello. Good evening. Thank you very much. Yeah. Thanks.
Shreya,
Shreya,
you're
you're
for
on mute. Hello and a very warm welcome to all of you and a very warm welcome to all the judges as well. So I'm Shreya Chakravarti. I'm from GMERS Medical College. I work with Clinic Case and I'll be the moderator for today. So without delaying any further, I would like to first begin with the rules and regulations of this competition. So we have 8 teams currently, and all the 8 teams will be presenting their cases which have been provided to them already. The format for the presentation shall follow this: the demographic data, then chief complaints, HOPI, past history, personal history, family history, differential diagnosis, examination, management, and final diagnosis. Each team has to be prepared with a personal PPT to present their case. They will be having 15 minutes to present their case. And now be telling about the judging criteria. So all the teams will be judged on the basis of 13 criteria, which are the demographic data, which will account for 5 points, the chief complaints data, that will account for 5 points again, HOPI for 10 points, past history for 5 points, personal history for 5 points, family history for 5 points, negative history for 10 points, differential diagnosis 10 points, general examination 10 points, systemic examination 10 points, final diagnosis 5 points. Questions by judges will be followed after this, and the way the contestants will be answering shall be judged as well. It will consist of 5 marks, and other than that, the PPT and the soft skills will also be consisting of 10 marks. So this is completely coming up to 100 points. So you all will be judged, and a total score of 100 is what you'll be judged upon. So if we may begin, the very first team that will be presenting is team number 3.
Ma'am, is
Are
it
you guys there?
number 34?
Hello, sorry, I couldn't hear you.
Ma'am, is it team number 34?
I think we can switch
Yeah,
off.
it's team number 34. Please join.
Team
Group
number
number
34.
30.
Yes,
Yeah,
team
group
number.
Yes, yes, ma'am. Ma'am, shall I share my screen?
Yes, you are supposed to share your screen.
1 minute. Ma'am, is it visible?
Yes, it's visible.
Right.
Oh. Good afternoon, judges. We are team number 34. I am Spurti Shailendra from Bangalore. My other teammates will introduce themselves.
Hello, I am Joel Elias Haji from Believers Church Medical College, Kerala.
Hello, am I audible?
Yeah.
I am Siddharth Nair from AIMS Bhubaneswar, third year.
Ma'am, shall we start with our presentation?
Yes, you may begin.
Yes.
Just a minute. Please keep your cameras on. The team presenting, please everyone keep your cameras on.
Hello.
Yeah, please start.
Hello.
Okay. Yes, ma'am. Yeah.
Am I visible and audible? Am I visible?
Yeah, you are visible and you're audible.
Hello. Okay. So good afternoon, everyone. We are team number 3 and we are given the first case. So I am going to present. So we are given the case number 1. Next slide. Next slide. Hello.
Yeah. I've changed the slide.
Case number 1, sir.
So that, can you see the slide?
No, I am in the first slide.
I've changed it. Ma'am, is it
Okay.
showing a patient detail slide?
No, actually, okay. So do one thing, stop sharing and share it again.
Okay, okay. Sorry, just 1 minute.
Oh, now it came.
Now it's coming. Okay, fine. I'll just keep it like
Put it on slideshow if you can.
now. Is it visible?
Yeah, it's visible.
Ma'am, the patient
the
detail
first
slide?
Yeah, the patient
The
details
patient details
slide.
slide is visible.
Yeah, okay.
Okay, so our case is a 35-year-old female who is a permanent resident of Bangalore, Mrs. ABC, and she is a homemaker by occupation, and she is a 12th standard pass. Next slide.
Has it changed?
No, it didn't change.
I'm so sorry. Is it visible
Yeah,
now?
it didn't. Huh.
Okay, I'll keep it like this. Sorry. Yeah.
The patient presented to the OPD with chief complaints of fever since 1 week and cough since 1 week, and she presented to the emergency department with chest pain, which is acute in onset, and breathlessness, which is also acute. Next slide.
Is it
Coming
visible?
to the history of the presenting illness, yes, it is visible. The patient was apparently normal 1 week back when she developed fever, which was high grade and remittent in nature. It was associated with chills, and the fever was progressively worsened over the last 2 days. And there was no diurnal variation in the fever. She also has history of cough, which was insidious in onset, progressive, and was associated with sputum or expectoration. The characteristics of the sputum are it was initially moderate in amount and mucopurulent in consistency. It was non-foul smelling and there was no hemoptysis. And since the last 2 days, the character changed and it became copious in amount and purulent with thick substance. She presented to the emergency room with chest pain, which was around the sternum, and it was a sharp pricking type in character. It was intermittent in nature and non-radiating, and the pain got aggravated by coughing in the sternal area. And she has associated symptoms of nausea and sweating and hyperventilation. And there was a shortness of breath, which was sudden in onset. It was not associated with any wheeze, and there is no history of orthopnea or paroxysmal nocturnal dyspnea. Next slide, please. Coming to the negative history, there is no history of loss of appetite, no history of significant weight loss, and there is no history of vomiting. Coming to the past history of the patient, she was a known case of hypertension, gestational diabetes mellitus, and chronic bronchitis. She had a history of cerebrovascular accident 3 years ago, and she is not a known case of diabetes mellitus type 2, hyperlipidemia, or any kind of heart disease. There is no history of asthma or epilepsy. And there is no history of similar episodes in the past. There is no history of deep vein thrombosis, and there is no history of contact with tuberculosis. Am I audible to all?
Yes, you're audible.
Coming to the personal history, she has a mixed Indian diet, and the appetite is reduced. Her appetite is reduced, and the sleep pattern is normal, and the bowel or bladder habits are regular, and she has no substance abuse. Coming to the family history, there is no such significant family history. Next slide will be presented by my teammate. Thank you.
So to summarize the case, here is a 35-year-old female, known case of chronic bronchitis, presents to the ER with history of high-grade fever with chills and productive purulent cough since a week, an acute onset of pleuritic chest pain and breathlessness. So based on history, the differentials would be empyema thoracis, lung abscess, pleural effusion, pneumonia, and pulmonary embolism. So what are the points in favor of empyema thoracis? High-grade fever with chills, severe pleuritic chest pain, copious purulent sputum, breathlessness, nausea, and sweating. Points in favor of lung abscess, high-grade fever, copious purulent sputum, and points against absence of hemoptysis, absence of postural variation of symptoms. For pleural effusion, breathlessness and pleuritic chest pain are points in favor, and copious purulent sputum is points against. For pneumonia, fever with chills, productive cough, and pleuritic chest pain are points in favor, and purulent copious sputum are points against. For pulmonary embolism, acute chest pain, acute breathlessness, and history of CVA are points in favor. Productive cough, no recent history of hospitalization, immobilization, and long travel, and no history of DVT are points against. Now moving on to general physical examination. The patient appears anxious. Vitals, respiratory rate was 25 cycles per minute, thoraco-abdominal. Pulse rate was 116 beats per minute, regular, normal volume and character. Blood pressure was normal, and she was febrile. JVP was not raised. Clubbing was present, and there was no pallor, icterus, cyanosis, lymphadenopathy, or edema. Now moving on to respiratory examination proper. Upper respiratory tract examination. The nasal cavity, oral cavity, and pharynx appears normal. On inspection, the chest is normal in shape and bilaterally symmetrical. Trachea appears to be shifted to the right side. Apex beat can be visualized in the left mammary area, and intercostal fullness over left region is appreciated. No dilated veins, scars, or sinus visible on chest wall. Kyphoscoliosis or drooping of shoulder is not present. Movement of chest wall. The left side appears to be diminished than the right side. The right side appears normal. On palpation, the inspectory findings are confirmed. Trachea is shifted to the right. Apex beat palpable in the fifth intercostal space, medial to midclavicular line. Intercostal tenderness on palpation near the left sternal border. Measurement, left hemithorax shows reduced expansion. Chest movements. The chest movements are reduced in the infraaxillary and the infrascapular region on the left side. Tactile fremitus is also reduced in the infraaxillary and infrascapular area on the left side. Percussion. Percussion showed stony dullness in both infraaxillary and infrascapular region on the left side. All other regions showed resonant note. Auscultation over the left infraaxillary and infrascapular area showed reduced intensity of breath sounds. Next will be presented by my next teammate.
Good afternoon. Now, again, reviewing the differential diagnosis that we had kept in mind at the end of history, our first differential was empyema thoracis. At the end of investigations, that the points that are in favor are shift of trachea to the right side, reduced expansion, tenderness or palpation, intercostal fullness, reduced tactile fremitus and vocal fremitus, stony dullness, and decreased intensity of breath sounds on the left infraaxillary and infrascapular regions. Our second differential diagnosis of lung abscess have many points against at the end of investigation, such as presence of stony dullness and no added sounds like coarse crackles. Our third differential of pleural effusion has many points in favor at the end of investigation, such as shift of trachea to the right, reduced expansion, reduced tactile fremitus, vocal fremitus, stony dullness, and decreased intensity of breath sounds. But the sign of tenderness on intercostal space palpation is not favoring pleural effusion. Our fourth differential of pneumonia is also supported by reduced expansion on the left side and decreased intensity of breath sounds. But other features such as tracheal shift, stony dullness, decreased tactile and vocal fremitus are against it. And also absence of other added sounds such as bronchial tubular breath sounds are against the diagnosis of pneumonia. Coming to the next step, that is investigations. The first investigation that we'd like to do would be complete blood count. Based on a patient's symptoms, we would be expecting to see the presence of leukocytosis. C-reactive protein can also be done, which could be high in infectious states. Since she has productive cough, microbiological examination of sputum will be done, which consists of the following steps, which will be gram stain, acid-fast stain, culture, and drug sensitivity. An ECG is also done to rule out the presence of an MI because of her presenting with acute chest pain. The next investigation, that is a chest X-ray. This is a plain radiograph, posterior anterior view of the chest. In this X-ray, the findings that are visible are, starting from the airways, the trachea appears to be shifted slightly to the right. Coming to the left lung fields, there is presence of homogeneous shadow in the middle and lower lung fields, with also the presence of a Ellis S-shaped curve, which is increasing height of the opacity as it comes towards the axilla. And there's also presence of an air fluid level. Our next investigation would be an ultrasound to find out exact position of the fluid accumulation, presence of pleural thickening, and to find out if there is a uniloculated or multiloculated collection of fluid. On a CT scan, we would be likely to see the presence of the split pleura sign, which shows the presence of fluid present between the two layers of the pleura and presence of an air fluid level. Another investigation that we would like to do would be aspiration of the pleural fluid with the help of ultrasound guidance. On gross examination, we are likely to see the presence of purulent thick pus with other features favoring empyema, such as glucose levels less than 60 milligram per deciliter, high LDH levels more than 1,000 international units per liter, low pH with less than 7.2. We would also do a gram stain and culture and sensitivity to demonstrate the organism and to be able to decide the course of treatment. So at the end of investigations, coming to the diagnosis and summarizing, we have a 35-year-old female, known case of chronic bronchitis, presenting to the ER with complaints of severe pleuritic type of chest pain, breathlessness, purulent cough and fever with chills since a week. On examination, her trachea is deviated to the right. She has reduced movements on the left side, reduced tactile fremitus, tenderness to palpation and intercostal fullness, stony dullness on percussion, reduced breath sounds on auscultation in the areas of left infraaxillary and infrascapular, which suggests the left lower lobe region. So our provisional diagnosis based on history, examination, and supporting investigations would be that this is a case of left-sided empyema thoracis with a bronchopleural fistula as a complication. Coming to the management of the patient, since we already discussed investigations, coming to the treatment, our first aim would be to control the infection, which we will do with the help of antibiotics. Initially, the patient can be started on empirical antibiotics such as intravenous coamoxiclav along with metronidazole. But once the results of the pleural fluid analysis is reported, we can change the antibiotics accordingly. Drainage of pus is important in order to obliterate the space and help re-expansion of the lung. In case of a presence of an early or small empyema with thin fluid, aspiration with a wide bore needle can be done, which may have to be repeated. Or we can also do a closed tube thoracostomy. Tube drainage are the most dependent part of the empyema. In cases of chronic empyema or presence of a pleural of thickening and fibrosis of the empyemous fluid, we can also do surgical decortication in case exactly when the tube drainage fails or pus is thick and loculated, or when the visceral pleura has thickened so much that it's preventing the lung to re-expand. In such cases, we can do a surgical decortication procedure. Bronchopleural fistula also maybe have to correct it surgically. And if another option would be open drainage with rib resection to eliminate the infection. Thank you.
Thank you, team. You may stop sharing the screen now. Now we would ask the judges to please question our team. Rupali ma'am, you may please proceed.
So first, I would like to congratulate for the nice presentation. You have discussed the differentials very well, along with all the management, the investigation part. So everything has been discussed very well. Some few basic questions I would like to ask. The chief complaints, if we talk of, other than fever, we had cough and shortness of breath. So based on cough and shortness of breath, what are the two major organ systems that you need to differentiate? The respiratory and the cardiovascular. So what are the two major points based on which you decide whether it is a respiratory problem or a cardiovascular problem? So
there was no orthopnea and no PND.
So just if I ask you based on cough and shortness of breath, if a patient comes with just these two complaints, cough and shortness of breath, so based on that, how do you decide on the history itself other than
Ma'am, yes, ma'am. Ma'am, cough starting initially with then followed by shortness of breath is most likely respiratory, whereas breathlessness followed by cough is most likely CVS system. And also in our case, because of cough with expectoration, it is most likely towards the respiratory system.
Okay, since you discussed the investigation part, so I would like to ask you only. So when do we call it an adequate sputum sample? Sputum examination is a very important investigation in such a patient. So what are the criteria to say that the sputum sample is adequate or not?
Yes, ma'am. Ma'am, usually we prefer either a sputum sample on spot or an early morning sputum sample. Early morning sputum sample would be preferred because to prevent any other source of decontamination.
That's fine, but on microscope.
On examination, yes, ma'am. Yes, ma'am. Salivary epithelial cells presence of that would be indicating that this could be more of salivary fluid rather than the sputum as such.
Hello.
The person who was describing the examination part, one question from in general physical examination, what are the stigmata of tuberculosis that you can look for head to toe? That point have you mentioned? The stigmata of tuberculosis on general physical examination that you need to look for. The person who has presented examination can tell that.
Hello, ma'am. Ma'am, there can be matted lymph nodes on physical examination. Then
signs of cutaneous TB.
Cutaneous manifestations of TB can be present.
Like
erythema nodosum.
Erythema nodosum is a.
Erythema nodosum.
Ma'am, erythema
nodosum.
Ma'am, usually on the calves and the arms.
Or
Or ma'am, sorry, ma'am, over the tibia, over the shin.
Tibia.
Shin of
Over
the
the shin.
of
Yes,
the
ma'am.
How
Yeah.
about described? What are the causes of erythema Some common causes.
Ma'am, the most common is streptococcal pharyngitis can cause erythema nodosum, and other causes such as Crohn's disease can cause erythema nodosum, and Behçet's disease.
Okay.
Then ma'am, drug
Sarcoidosis.
Drug intake can cause.
Yes, leprosy can be there. Sarcoidosis can be there. Yes. Okay. So, and what else? So, other than
lupus vulgaris.
lupus vulgaris, then what else?
Lupus vulgaris, erythema nodosum. Crofulloderma.
Crofulloderma.
What else?
Cutaneous TB.
Inflammatory bowel disease.
No, TB markers, ma'am is asking.
General physical examination, something in the eye you can look for?
Yes, ma'am, flictin.
Yes, clear conjunctivitis can be there. What else? In nails, something else you can look for? Thickened spermatic cord.
Yes, ma'am.
So that can also be one of the signs you can look for. And one more important thing is, when you are having a case of pneumonia or lower respiratory tract infection, always look for the sinus tenderness as well.
Yes,
ma'am. Specifically mention, okay, you have mentioned the upper respiratory tract, but specifically the sinus tenderness is important.
Yes, ma'am.
Would Archana ma'am like to ask some questions, ma'am? Is ma'am around?
Archana ma'am, are you there?
Yeah, I'm very much there.
Yeah, would you like to ask any questions?
Yeah, what is empyema necessitans?
Empyema necessitans is the complication of empyema thoracis, which where there is a rupture of the pus within the pleural cavity to form a subcutaneous abscess or sinus.
How do you say on a clinical examination patient is having the bronchopleural fissura?
Ma'am, okay, ma'am, she has complaints of thick purulent sputum since the past 2 days, which could suggest the pus which is coming from the empyema, the pleural cavity.
Very difficult actually, but anyway. Empyema. Okay, that is one thing. So what type of the breathing pattern you will get in bronchopleural fissura, which you are not told in the presentation? There are different types of breathing.
Ma'am, normally we have thoraco-abdominal or abdominothoracic breathing.
No, in the over the auscultation over the lungs. It is a vesicular or the
Vesicular is
bronchial.
there, bronchial is there, and bronchial itself there is tubular, amphoric, and cavernous. Then there is bronchiovesicular breathing also. Hello, ma'am.
So out of these three, which is the so which type of the bronchial breathing
Is it
will be there in the
amphoric breathing?
bronchopleural fissura?
Is it amphoric breathing?
Yes. Yeah, okay.
Yes, ma'am.
Ma'am, any more questions you have?
No, thank you.
Okay. Thank you, ma'am.
Good presentation.
Thank you, team.
Thank you.
Thank you, ma'am.
Team.
Anybody is looking for the time?
Yes, ma'am, we are looking for the time.
So how much
15
time?
minutes. So they finished just 1 minute before 15 minutes.
Okay.
And for the question answers also, we are counting the time. It has to be within 10 minutes only. So we'll let you know if.
Okay.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you, team. It was a wonderful presentation.
Thank you. Thank you, ma'am.
So now we will have team number 1, that is group 8. We have Himanshu, Swati, and Bhargav. Please start sharing your screen. and start your presentation.
Hello, can you guys see the
Please switch on
screen?
your cameras. Yeah, the screen is visible. Please switch on your cameras as well.
Yeah, fine. So shall I start?
Yeah, you may begin.
Hello everyone, my name is Himanshu Vayan. I'm a final year medical student from Kasturba Medical College, Manipal. I'm here with Dr. Bhargav Banushali and Swati Algur. We are from Group 8 and we have been given case number 5 for exquisite, the clinical round, the final round of the clinical round. So this was the clinical winner given to us. We were given case number 5 and I will be going through the history taking part of case number 5. So patient particulars and the chief complaint. So we have a 37-year-old male, Mr. X from Mumbai, who is an executive by profession, has come with chief complaints of recurrent upper abdominal pain since 2 years. The history was obtained from the patient himself and is reliable. So when the patient complains of recurrent upper abdominal pain, just by that history, there are a few differentials which come to our mind. The common differentials include, of course, the most common thing that comes to our mind is gastroesophageal reflux disease, classically coming in as a burning pain in the epigastrium. We could have a peptic ulcer disease. We could have acute cholecystitis, since we do not know if it's a midline or a right upper quadrant pain. Acute pancreatitis can present as recurrent upper abdominal pain. Irritable bowel syndrome. The less common pathology, what we refer to here is the non-GI pathology, which can come as upper abdominal pain, atypical angina, but what we call as anginal equivalents, mainly related to the inferior wall pathology. Aortic aneurysm, largely asymptomatic in the population, but can sometimes present as the laking pain. Inflammatory bowel disease, the Crohn's and ulcerative colitis involving the transverse colon, or maybe a stomach Crohn's can come as recurrent upper abdominal pain. Mesenteric ischemia classically presents as a postprandial abdominal pain, but from the history given, we might consider it as a differential. And although the patient is a very young patient, sometimes we might just keep at the end of a differential malignancies of the stomach, pancreas, and colon as well. So this is just from the chief complaint that we have derived. History of presenting illness. The patient was apparently in his usual state of health until about 2 years ago. Since then, he has been experiencing recurrent episodes of upper abdominal pain. The patient says that he experienced the symptoms quite infrequently, about once or twice every month, and describes each episode as a burning pain located in the epigastrium with no radiation of pain, particularly occurring about 2 to 3 hours of taking food and relieved rapidly by eating food and taking antacids over the counter. And he says that he is completely pain free between the episodes of pain. Since the past 3 weeks, he has been experiencing his symptoms more frequently, about 3 to 4 times a week, often awakening him from his sleep, but the quality and nature of his pain have remained the same. He owes this increase in frequency to an increase in stress at workplace. Is again completely pain-free between the episode. So, if taken a certain negative history, the patient doesn't report any history of nausea, vomiting, belching, bloating, or any other dyspeptic symptom, sore throat or hoarseness of voice, alteration of bowel habits, no diarrhea or constipation. No history of passing frank blood in the stools. There is no history of yellowish discoloration of skin and eyes, and no history of chest pain, syncope, or sweating. The patient doesn't report any history of swelling in the upper abdomen, difficulty swallowing, or pain while swallowing, that is, no dysphagia or odynophagia, vomiting out blood or passing black, tarry, sticky stools, that is, there is no history of hematemesis or melena. There is no history of sudden increase in severity of abdominal pain or generalized abdominal pain in the past 2 years. No history of fatigue, dyspnea, or pallor. There is no history of tingling, numbness of extremities, or swaying when eyes closed. And we asked this particular history because the patient has been on antacids for over 2 years, and antacids reduce the acidity of the stomach, thus reducing vitamin B12 absorption finally in the ileum. So yeah, this history was asked to rule out vitamin B12 deficiency. The patient also said that he has put on weight since the past 3 weeks or so. History of past illness. There is no history of diabetes mellitus, hypertension, ischemic heart disease, or bronchial asthma. No known allergies, and no history of prior gastric surgeries. Treatment history. There is a history of use of antacids over the counter since the past 2 years. The antacid preparation contained magnesium and aluminium. No history of use of over-the-counter painkillers. No history of use of traditional medicines for his pain. Personal social history, diet. He consumes a mixed diet. He says that he likes his food spicy. He also says that he eats a lot of dark chocolates. Of late, he has also been using a lot of caffeine to stay awake for his work. Sleep, he reports reduced sleep owing to his work. Further, his pain has been disturbing his sleep, so he has to wake up to eat whenever he gets his pain. The appetite is normal, although he has been eating a lot lately. Bowel bladder regular. Addictions, there is no history of consumption of alcohol or tobacco in any form, no history of smoking. He doesn't hold any card for medical insurance. He lives in a pakka house in the suburbs of the city. The water supply comes from the municipality. Family history, he's married, but he has no kids. No history of similar complaints in the family. There is no history of upper GI malignancy in the family. So at the end of history taking, the differential diagnosis, the most probable diagnosis is an uncomplicated duodenal ulcer. Probably lifestyle induced, considering the increase in stress, considering his dietary habits, that he has got an increase in history of caffeine intake, increase in intake of dark chocolates and spicy food as well. It doesn't give history of NSAID use, so it is non-NSAID associated, but H. pylori association can't be ruled out from history alone. But the thing to note is that we think it's an uncomplicated duodenal ulcer at the moment. Differentials, a gastric ulcer, although classically happens in an elderly patient, males and females more equally affected. The gastric ulcer pain will have pain on taking the food, and the patient will also say have weight loss due to, because he will be vomiting as soon as he takes the food, because he'll get intense amount of pain on taking the food. GRD, considering the burning upper epigastric pain, and a diagnosis of exclusion, non-ulcerogenic dyspepsia or functional dyspepsia as well has been considered. But our probable diagnosis at the end of history is an uncomplicated duodenal ulcer. Swati will now be continuing with the examination.
Good evening. So I'll be starting with the examination part. I'm Swati Algur. Next. General physical examination. The patient is conscious, coherent, cooperative, and well oriented to time, place, and person. He was calmly sitting and didn't look fidgety or agitated. Was moderately built and nourished with a body mass index of 23.2 and waist to hip ratio of 0.83. Next. General physical examination. So his vitals are: pulse is 72 beats per minute, regular rhythm, normal volume, normal character, arterial wall is not thickened, peripheral pulses are felt with normal intensity bilaterally. His blood pressure is 132 by 60 mm of mercury on the right arm in a supine position. Respiratory rate is 18 cycles per minute, predominantly abdominothoracic pattern, and depth is normal, and there is no use of accessory muscles seen for respiration. Patient was afebrile. Axillary temperature was of 37.3 degrees Celsius. Head to toe examination. There is no evidence of pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, pedal edema. No evidence of dehydration, no knuckle hyperpigmentation or spooning of nails. This examination was done to rule out any kind of B12 deficiency. No supraclavicular lymphadenopathy or umbilical nodules. No evidence of atherosclerosis. Next, inspection. Shape of the abdomen is normal. Flanks are not full. Umbilicus is central and everted. All regions of the abdomen move synchronously with respiration. There is no mass or fullness noted. No visible pulsations. No visible peristalsis, nor dilated veins or scars or sinus or any fistula. External genitalia was normal. Normal hernial orifices. Per abdominal examination, so palpation, no local rise in temperature, tenderness, guarding, or rigidity, no evidence of any organomegaly, no mass was felt per abdomen. On percussion, tympanitic node over the entire abdomen was seen, a liver span of 11, almost of 11 centimeter was seen, no evidence of free fluid in the abdomen.
On auscultation, 4 vowel sounds heard in 60 seconds, no additional sounds. Colorectal examination was normal. Review of other systems. Cardiovascular system, S1, S2 heard, no added sounds. Respiratory system, normal vesicular breath, sound heard bilaterally over all 8 lung fields, no added sounds. Central nervous system, no focal neurological deficits. So, as there was not much to rule out in this, as per the examination, so no evidence of anemia was seen, no evidence of B12 deficiency was seen, no evidence of bleeding, no evidence of perforation. So, the most probable diagnosis over, according to examination, is uncomplicated duodenal ulcer. Also, differential diagnosis are other differential diagnoses are gastric ulcer, gastroesophageal reflux disease, and non-ulcerogenic dyspepsia. So from here, Dr. Bhargav will continue.
Hello, am I audible?
Yes, sir, you're audible, sir.
I am Dr. Bhargav Banusali, intern from BJ Medical College, Ahmedabad, and I will taking the management part of this case. And alarming symptoms and signs in suspected peptic ulcer disease are new onset dyspepsia in greater than 45 years, unexplained unintentional weight loss, hematemesis and melena, anemia, dysphagia or odynophagia, persistent vomiting, family history of gastric malignancy, and severe abdominal pain radiating to the back, generalized pain abdomen. So our patient doesn't have any of these, so we can start level 1 management. Level 1 management is investigation, a blood test, complete blood picture, hemoglobin and WBC count, liver function test, serum amylase and lipase for pancreatic function, and vitamin B12 and folate levels. Stool test for occult blood is negative, and serology for Helicobacter pylori antibody is positive. At first visit, treatment is a dietary modification, small frequent meals 5 to 6 times per day, avoid eating late at night, avoid chocolate, coffee, and carbonated beverages, avoid spicy and hot foods, eat, eat sitting in upright position, include vegetables and fruits in diet, particularly those rich in vitamin C, and if non-vegetarian, include seawater fish containing omega-3 fatty acids. Other advices are do not smoke or consume alcohol in future, yoga or meditation for stress relief, half an hour a day, and avoid taking over-the-counter painkillers. And we have given a trial of proton pump inhibitors like omeprazole 20 mg, lansoprazole 30 mg, or pantoprazole 40 mg, rabeprazole 20 mg, or esomeprazole 40 mg. We can give any of these. And in follow-up visit, patient was put.
You have only 3 minutes left. Please conclude fast.
Follow-up visit is patient was put on this empirical therapy for 2 weeks. So his symptom is improved. His serum Helicobacter pylori antibody testing has come positive. Although his current flare-up was attributed to his increasing stress, he has been having recurrent pain since almost 2 years. Thus, even though the test doesn't indicate active infection, positive result is significant, and we would want to start him on empirical therapy. Other tests are invasive test is upper GI endoscopy and rapid urease test, and non-invasive tests are urea breath test and stool antigen testing. So empirical therapy is proton pump inhibitor 2 times a day, amoxicillin 1 gram 2 times per day, and clindamycin 500 milligram 2 times per day for 7 to 14 days, and call the patient after for follow-up after 4 weeks of stopping therapy and check for Helicobacter pylori eradication using non-invasive testing like urea breath test. If it is eradicated, advise adherence to dietary modification for rest of life and maintenance dose of proton pump inhibitor. If it is not eradicated, consider case is resistance and start alternate regimens for this. Alternate regimens are second line levofloxacin plus amoxicillin plus proton pump inhibitors. Also, quadruple therapy is there for like colloidal bismuth sulfate therapy. And fourth line also we can consider rifabutin plus amoxicillin plus proton pump inhibitor. Thank you.
Thank you, team. Now we would like the judges to ask you a few questions. Please proceed.
Again, thank you so much for the wonderful presentation. You have covered almost everything in the history, in the examination, and also in the treatment. So you have tried to summarize everything possible. Just few questions. What are the side effects of chronic consumption of these antacids? Whether the antacids as well as the proton pump inhibitors. Yes. Some side effects of chronic consumption of these antacids, commonly consumed over the counter by many of our relatives, family members. So, yes, any one of you would like to tell me common side effects?
Yeah, I'll start with it and probably Swati will take over.
Yeah.
The common side effect, basically the mechanism is that they reduce the acidity of the stomach, and we know that acidity is a must, one for absorption of certain elements and two to prevent colonization by certain bacteria. So if antacids are used over a long period of time, one kind of side effect would be that the acidity will be reduced. So consequently, the absorption of iron and B12 will be reduced. So over the long term, patient will have iron deficiency anemia and B12 deficiency anemia. Secondly, the colonization is increased. For example, a simple H. pylori. The easiest way to eradicate H. pylori is to maintain the acidity of the stomach. So H. pylori infestation is also higher in chronic antacid use. And I think Swati can add over if
Any other specific side effects of the aluminium or the magnesium containing antacids?
Yeah. If the magnesium content is too much, then magnesium can cause with kidney disease also.
Okay.
The
aluminium one? Aluminium one?
Hello, we asked regarding alteration of bowel habits. That was also to rule out the side effect of magnesium and aluminium. They cause constipation and diarrhea, but in combination, the side effects are negated. And that's why most antacids now have a combination of both magnesium and aluminium components.
Any other specific side effects of aluminium containing antacids?
Hypophosphatemia.
The neurotoxicity part, anyone? Okay. And what about
magnesium causes Parkinsonism, and aluminium as an it's implicated in Alzheimer's, I guess.
Okay, what about proton pump inhibitors? Can you tell me some side effects of the proton pump inhibitors?
Gynecomastia for omeprazole.
Anything else?
Gynecomastia and then
Okay, what about can one of you summarize the differences between gastric and the duodenal ulcers? Which of the two is more likely to be malignant?
Gastric ulcer is likely to be malignant.
Okay.
Gastric ulcer presents in elderly patient. The male to female ratio is the same for gastric ulcer. Gastric ulcer classically is increased intensity of pain on consumption of food, whereas duodenal ulcer is relieved by food intake. And gastric,
yeah, okay.
Yeah,
you have already mentioned that in the presentation as well. Okay. I think that will be all. Ma'am can ask few questions.
Hello.
Yes,
can you hear me? What are the commonest complications of this gastric ulcer or a duodenal ulcer?
Duodenal ulcer can undergo perforation. The anterior duodenal ulcer usually perforates. Posterior duodenal ulcer bleeds from the gastroduodenal artery. And there is something called a kissing ulcer, which is anterior plus posterior combined, which can present with gastric outlet obstruction due to stenosis. These are three common complications of duodenal ulcer. But a gastric ulcer can undergo malignancy, for example, over long-term gastric adenocarcinoma. But if it's associated with H. pylori, it can also give rise to maltoma and lymphoma.
Okay, that's enough. Thank you.
Thank you, judges. Thank you, team. It was really informative and very well presented. And now we would like to proceed with team number 6, that is group 12. So group 12, please come aboard and start with your presentation.
Is my screen visible?
Contestants, please switch on your camera as well. Yeah, it is visible.
Okay. So good evening, everybody. I am Aishwarya Deshpande, and we are team number 12, and we have been given case number 8. So I'd like my other team members to please introduce themselves.
Hello, good evening. Hello, good evening, everyone.
Yeah, please continue.
Hello, I'm Shravani, final year student from SGMC Kolar.
Hello, I'm Sneh from Jimmer's Medical College, Sola, final year student.
Okay, so I will begin with the case now. My patient, Mr. XYZ, aged 42 years, residing in Bangalore, working as a basketball coach belonging to class 2 of the modified BG Prasad classification, presented to the ED on 31st October 2020 with the chief complaints of severe chest pain since 1 hour, which was sudden in onset. My patient was apparently all right 1 hour back, after which he developed new onset of chest pain, which was sudden in onset, retrosternal location. Pain is sharp in quality and constant in nature. The pain was not relieved by 3 doses of nitroglycerine, which was given by the while bringing him to the ED. Pain is not radiating to the neck, jaw, and not related to respiratory movements, chest wall movements. There's no history of pre-syncope, syncope, loss of consciousness, or altered mental state. No history of recent travel, prolonged sitting, shortness of breath, fever, or cough, recent trauma, or heavy lifting weights. There's no history of numbness, tingling, weakness of limbs, or any pain in the limb. There's no difficulty in swallowing or hoarseness of voice, and no flank pain or abdominal pain. The patient had no similar complaints in the past. He is a known he's a known case of hypertension for which he is on enalapril. There's no history of diabetes mellitus, asthma, tuberculosis, or epilepsy. The patient had no history of any previous hospitalizations and surgeries. Then the patient takes a mixed diet with a normal appetite. The sleep is undisturbed and adequate. With he has normal and regular bowel and bladder movements. There are no history of any addictions and no history of any allergies. Then the patient has no similar complaints in the family, no history of sudden cardiac death in the family as well. Just to summarize the history, our patient has a sudden onset retrosternal chest pain, which was not relieved by medication. And it was different. The blood pressure was different in both the arms. Long history of hypertension and the patient has a tall habitus with a funnel-shaped chest. So this suggests a probable Marfan syndrome. Now the next person will continue the general examination.
So here the patient is moderately built and well nourished, and he is conscious, diaphoretic, restless, oriented to time, place, person. His BMI was 20 kg per meter square. He's coming to the vitals, he is afebrile and heart rate is 118 beats per minute. His blood pressure in the right arm is 156 by 64 mmHg, and in the left arm it's 188 by 74 mmHg. Here you can notice more than 20 mmHg difference in both the arms, which is significant. And coming to the respiratory rate, it is 22 breaths per minute, which suggests he is tachypneic. And oxygen saturation is adequate. Pulse is rapid, bounding, high volume pulse, normal in character, no vessel wall thickening, no radial or radiofemoral delay. All peripheral pulses are felt. JVP is normal and Kussmaul sign is negative. There is no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Coming to head-to-toe examination, he is tall and thin, and head and neck and oral cavity are normal. Eyes show superotemporal subluxation of the lens, and there is no cataract. Hands and legs are long and flexible. Thumb sign and wrist sign showed positive. Chest, the shape of the chest is funnel shape. It is pectus excavatum. Spine is scoliotic, and arm span is more than height. All these features suggestive of Marfan syndrome. Then the patient is lying on a stretcher with eyes closed, appears uncomfortable and diaphoretic. He is a tall man with long arms and legs. As a patient, chief complaints of chest pain, first I would like to examine cardiovascular system. On inspection, his chest is funnel shaped and bilaterally symmetrical. Apical impulse is visible at the midclavicular line, probably in the fifth intercostal space. Trachea appears to be in the midline, and JVP is normal. There is no precordial bulge. There are no swelling, scars, sinuses, or dilated veins, visible pulsations, or any color change in the overlying skin. Inspectory findings are to be confirmed on palpation. Apex beat is palpable at the fifth intercostal space, 1 centimeter medial to midclavicular line. It lifts the fingers briefly. Trachea is centrally placed. There is no parasternal heave or thrills or tenderness. Coming to percussion, left border of the heart, the apex beat is at fifth intercostal space at the midclavicular line, and at third and fourth intercostal space, it's near the sternal edge. Right border is under the sternal edge. Next, auscultation, S1 is normal and S2 shows narrow splitting and S4 is present. Coming to murmurs, there is a soft early diastolic murmur felt after A2 and it is best heard at the left sternal border. Coming to the other systems, respiratory system shows normal rate, bilaterally symmetrical movements, bilateral vesicular breath sounds are heard, and there are no other added sounds. Abdominal examination, soft, non-tender, and there is no organomegaly, and normal bowel sounds are heard. No neurological examination, there are no focal neurological deficits. My
Hello, am I
next
audible?
colleague.
Yeah, you're audible.
Okay, so according to history and physical examination, for a diagnosis of patient, we have to first rule out the other things. So for that, we have a differential diagnosis. The first thing which comes to our mind for acute chest pain, it is coronary artery disease or acute coronary syndrome or unstable angina, which can have aortic involvement according to auscultatory findings. First of all, ruling out the coronary artery disease, we have to check for the ECG examination, but both these conditions go hand in hand. Our probable diagnosis, according to now, is now of acute ascending aortic dissection, but aortic dissection can cause coronary artery disease, and they both conditions go hand in hand. So it is very important to differentiate both the things. Acute MI can be differentiated according to ECG, cardiac enzymes, and then next differential is coarctation of aorta or bicuspid aortic valve, because these both condition can cause aortic dissection. Coarctation of aorta is most commonly seen in female, which associated with Turner syndrome, same as for bicuspid aortic valve. Then another differential is acute aortic aneurysm, which can be complicated by rupture into mediastinum, which shows a widened mediastinum. So it is also important to rule out, which can be done via CT angiography or MR angiography. Then next is pulmonary embolism. Our patient has sudden onset of acute chest pain, but he has no history of recent travel, surgery, or any fractures, and no pleuritic chest pain. So that rule out the pulmonary embolism. Then next can be Boyer-Harvey syndrome or esophageal perforation, which can cause pneumomediastinum, which can be ruled out on examination via Hammond's crunch or subcutaneous precipitous. Then another differential can be acute chest syndrome, which can be caused by a sickle cell disease, but he has no any family history of sickle cell or anemia per se. Another is myocarditis, which can precede by acute viral infection of upper respiratory tract, which is negative for our patient. Another differential for acute chest pain can be pain from chest wall, which can be musculoskeletal pain like costochondritis. But the differentiating point here is chest wall pain is palpable, which is on palpation and tenderness is seen, but on respiratory or cardiovascular tender. Then another is GI-related complaints like gastroesophageal reflux disease, esophagitis, or perforated ulcer or hiatal hernia, which have to be ruled out for another investigations, and they are related to food habits. Another last one. Hello.
Yeah, you're audible. Please continue.
Another last but not the least is pleuritic chest pain, which can be due to pleurisy or pericarditis. Pericardial pain is increased on supine when patient is on sitting and supine position, and pleural chest pain is increased with inspiration, and it is characteristically sharp pain with other respiratory complaints too. So according to all the sign symptom and the examination or probable diagnosis is please next slide actually. Okay. Our probable diagnosis according to sign symptom and examination, we have two diagnoses, a probable diagnosis. First is acute ascending aortic dissection due to Marfan syndrome precipitated by hypertension, which is complicated by mild acute aortic regurgitation with no sign symptom of infective endocarditis, rheumatic heart disease, and not in acute cardiac failure. Another thing we must rule out is coronary artery disease or acute MI. So for the management of the patient, next slide. Management of the patient, first thing first for investigation, actually acute MI and aortic dissection both are emergency, acute medical emergency. So we have to first stabilize the patient, and hand in hand we have to go for blood studies, normal CBC, complete blood count, hemoglobin, hematocrit and grouping, cardiac enzyme, ECG, and another renal function test, and specific examination for ruling out diagnosis. So management of the patient, as soon as patient present to emergency department, we have to preserve the airway, breathing and circulation. The first thing we have in mind is to rule out the myocardial infection. So we have to go for the ECG and rule out the myocardial infection along with a cardiac enzyme like troponin T and I, and myoglobin and CKMB. In our patient, cardiac bioenzymes were negative, so it's a diagnosis of acute ascending aortic aneurysm. So according to a risk assessment of patient based on aortic dissection detection risk score, actually three categories are provided according to past history, like family history of familial ascending aortic dissection, then Marfan syndrome, then similar complaint in family. The score 1 is given, then pain characteristic like pain in a retrosternal area, which is radiating to back, which is sharp in quality and stabbing in nature, and not relieved by
Contestant,
any.
you have only 2 minutes left. Please start concluding now.
Okay. Next slide, please. So for the management of the patient, there are two types of aortic dissection according to Stanford criteria: Type A and Type B. Type A is surgical emergency, and Type B is managed conservatively. So first of all, we have to think for management of the patient. We have to think for hypertension, which is anti-impulse therapy. We have to first of all give the esmolar or beta blocker, followed by vasodilators. We can't give vasodilator first because it can cause reflex tachycardia. Anti-impulse therapy is based on a change in pressure according to change in time. So we want to prevent the distal edge of the dissection as near as possible. and prevent any further complication. For diagnosis, it is a CT angiography is the best gold standard test, followed by transesophageal echocardiography, which can also show any valvular or heart disease. Next slide, actually. Next two. Okay, it's that. Okay, transesophageal echocardiography has most sensitivity, and CTA is most specific test for aortic dissection. Thank you.
Thank you, team. Now over to the judges for questions.
Again, nice presentation. So wonderfully presented, and you have covered almost all the aspects. You were mentioning something regarding sensitivity of the echo. So how much is the sensitivity of the echo, the transthoracic echo? Any idea how much is it?
Actually, if we do transthoracic echo, it is actually 90 to 95% sensitivity, and thoracic echocardiograph is less sensitive.
Okay. Okay. Now, what are the criteria used for Marfan syndrome diagnosis? What do we call them? The criteria?
It's revised gen criteria, ma'am.
Okay, so what are the things included? What is the classical triad of Marfan syndrome?
So there are many manifestations, ma'am. Coming to cardiovascular, it has mitral valve prolapse, acute aortic dissection, and eyes superiotemporal subluxation of the lens, cataract,
Marfan
tall hand.
Yes, triad of, I'm asking you, what is the classical triad of Marfan's?
Marfan habitus, the flexible joints,
yes,
and early presenile cataract.
Yes, the eye, yes, then, and the cardiovascular.
And cardiovascular manifestation.
The aortic aneurysm. Okay, this is the classical triad. Okay, what is
Cystic medial degeneration.
heart? Pomfret's heart. Have you heard of it? Pomfrets. Pomfret's heart. Any clue? Where do we see Pomfret's heart? Okay.
Ma'am, is it syphilitic aortic dissection?
No. In patients with pectus excavatum, can you now tell? What is it? On a chest X-ray in a patient with pectus excavatum, what do you expect the heart shadow to look like? It appears bigger.
Wider. Yes.
Breast sternum, though the heart may be normal otherwise. So that is known as Pomfret's heart. Your patient had pectus excavatum, so I was asking you this. What is the importance of pectus excavatum if a patient has? What does it indicate actually in any patient if you have? Okay, just one last thing. Which drugs are contraindicated in management of aortic dissection, acute aortic dissection?
All the inotropic and vasopressor drugs are contraindicated.
Okay. Specifically some vasodilators like?
Vasodilators like we should not give vasodilator before taking consideration of heart rate. So like sodium nitroprusside or nitroglycerin.
Okay. And hydralazine?
It can cause...
Okay. Just one last question. What is the name of the syndrome where you have Marfanoid features except the ocular involvement?
Homocystinuria.
Homocystinuria.
One of the causes which has to be ruled out when we have Marfan's. What syndrome? Where you have all these features of Marfan except the ocular manifestation.
Ehlers-Danlos.
No. It is LDS. What is the full
Loeys-Dietz syndrome.
Loeys-Dietz syndrome.
Okay.
Loeys-Dietz syndrome.
Okay, fine. So thank you. That will be all from my side. Over to Archana, ma'am, please.
How will you differentiate clinically the acute AR and the chronic or the rheumatic AR on auscultation?
Acute AR, there is a acute aortic regurgitation. So there is a early diastolic. There is a early diastolic soft murmur, and on a chronic AR there is a very hyperdynamic pulse, Then all the manifestation of chronic AR, which are the quincus sign, pulsating uvula, then knobbing of head, which are present.
So you will get all the peripheral signs of the AR.
Yes, on chronic AR.
Any site of the murmur is a difference? Because as you said, the second left intercostal space there is early diastolic murmur.
Yes,
in
left
chronic
side, yes.
AR, where will you get?
On a chronic AR, it is radiated towards the carotid arteries.
Any other difference?
And in chronic AR, there is all due to regurgitation, there is mitral valve leaflet movement. So there is a mid diastolic
See,
nervous
that is
stim.
all on clinical, on echo. So on clinical examination, so peripheral signs of AR you will get, plus the murmur is a different character as compared to the acute AR. Okay, fine. Thank you.
Thank you, judges.
To the
And thank you,
organizer,
Dean, for a wonderful presentation.
Dr. Shreya.
Yes, ma'am.
I just want to know, because
Yes, ma'am.
you have given this the questionnaires or the marks management. There is no column for the management. Why the team is giving the management part? Because I think they are the part 1, part 2 students, correct?
Yes, ma'am.
I'm not expecting the management from them.
Yes,
Ideally,
ma'am.
they
We
should
had
approach only the approach to the case and how to come to the diagnosis. These are all PG questions. That's what I feel. The PG like management, and I don't think so. They will, because that management part is the scoring system is not there in the management criteria.
Yes, ma'am. It's not there because even in
They're
the
investing 5 minutes in that.
Okay. So now on, if you would want, then we
You
can
ask
ask
Dr.
them.
Rupali also, because the management is not there, and these students are the just MBBS students, not even graduated. So some of them are the interns. So management, okay, the emergency management, it's okay, but then all the hi-fi things, it is not required. They at present, it's more important is the approach to the patient, how they are doing the examination, and how they are clubbing the history and the examination and coming to the diagnosis. That's what I feel. Anyway, just now we will continue. We will not interrupt there.
Fine, ma'am. Perfectly fine. Agree with you with that.
Yeah.
So,
Next
ma'am,
question.
if you both would agree, then we can ask them to omit the management part
Because what
from
has
the
happened,
next case only.
every team has a 3 students, and the one student has taken the management. So then that will be difficult for them to conclude that. Doesn't matter, but we will know more stress on the clinical examination and the history.
Okay, ma'am.
Yeah. Thank you.
Thank
This
you,
is my
ma'am.
suggestion. Don't take this
Yes,
as
ma'am.
yeah.
Okay, so now we will have team 7, that is group 32. So please join the board and please start presenting your case.
Uh, Good evening, ma'am. Hello. Am I audible?
Yes, you're audible.
Hello.
Hello. Hello.
Yeah, you're audible. Please continue.
Good evening, ma'am. I'm Sachin Seller from BJ Medical final year student, and we are team number 7. I would like to introduce my other two teammates. Uh, One is Mehnaz, and other is Singla. Please introduce yourself, guys.
Good evening, ma'am. Myself, Bhavdeep Singla from GMC Patiala.
I
Hello.
am Menas. I am from GMRS Medical College, Sola.
Shall we start, ma'am?
Yes, you may begin.
Okay. Ma'am, demographic data. Uh, I'm presenting you a 37-year-old married male patient whose name is XYZ, liberal by occupation and Hindu by religion, resident of Palampur village, Uttarakhand. Chief complaint. Patient presented to emergency room today with a chief complaint of right iliac fossa pain since last 2 days. And I'm coming to the history of presenting illness. Please change the slide about it. Okay. Um, Patient was relatively asymptomatic before 2 days. Then he developed acute right iliac fossa pain. Pain is sharp, stabbing in nature, non-progressive, increase in severity today, and aggravated by movement. It is not relieved by any medication. Pain does not radiate to any other site, and no postural variation. Pain is 10 by 10 on Wong-Baker scale. Then associated symptom. Patient pain was associated with nausea, vomiting, non-bilious vomiting. Vomitus is copious in amount, odorless, contains semi-solid fluid. It's also associated with loss of appetite. Not uh, Pain is not associated with fever, any painful micturition, not associated with jaundice, then hematuria. It's not also not associated with diarrhea. Then past history. Patient has no history of similar complaints in the past, no history of diabetes, tuberculosis, hypertension, or any chronic disease of medical importance, no history of dyspepsia, or no history of parasite infection. Patient has no history suggestive of metastasis like altered sensorium, breathlessness, jaundice, backache, and bone pains. Patient has no comorbidities, no history of long-term drug intake or allergy or any blood transfusion, no history of any surgery in the past. Then I'm coming to the family history. Family history of patient is not significant. There is no history of any diabetes, hypertension, TB, or any chronic illness. No history of similar complaints in the family. Personal history. Patient takes mixed Indian diet. No history of any addiction or drug abuse. His bowel and bladder habits are normal. He has normal sleep pattern. He takes 6 to 8 hours sleep regularly. But from the last 2 days, he is unable to get adequate sleep due to severe pain in the right iliac fossa. Uh, then I'm coming to social history. Patient is uneducated. He belongs to lower middle class family. He has low household income. Now, next slide will be presented by my teammate about it. Hello.
I'm audible to you, ma'am? Now come on to the differential diagnosis. First one is acute pancreatitis. As in acute pancreatitis, there is a history of alcohol intake and it is absent in this. And in acute pancreatitis, there is a pain radiating to the back and epigastric tenderness. And next differential diagnosis is perforated duodenal ulcer. In the duodenal ulcer, there is a history of the dyspepsia and the pain start from the epigastrium and the migrate to the paracolic bladder. And the next DD is acute cholecystitis. As in the acute cholecystitis, there is a history of the jaundice, and we know jaundice is not present in this case. And the another DD is urinary colic. There is a history of the hematuria in the urinary colic, which is not present in this case. And the next diagnosis, differential diagnosis, is torsion of testis. In torsion of testis, there is a painful urination history, and it is not present in this case. And the next differential diagnosis is Crohn disease. In Crohn disease, there is a history of diarrhea and abdominal cramps. And in the acute colonic diverticulitis, there is a pain in the left iliac fossa. Now come on to the examination. General physical examination. Patient was examined after taking the informed consent in well-light patient room. Patient lying down comfortably. Patient is conscious, well-oriented to time, place, and person, and nutrition status is good, and he has normal build, and hydration status is also good. Vitals. The pulse is 82 per minute, good volume, regular, normally corrected, no radio-radial and radio-femoral delay, and in the respiratory rate 20 per minute, that is thoraco-abdominal type, and BP Blood pressure is systolic 128 and diastolic 86. And there is no clinical evidence of the icterus, clubbing, jaundice, lymphadenopathy, and pedal edema. Come on to the local examination. Examination of abdomen. Patient was examined in the supine position after exposing from the nipple to waist. On inspection, the shape of abdomen is flat and symmetrical. The umbilicus is inverted and midway between the xiphi sternum and pubic symphysis. All quadrants move equally with the respiration. There is no visible lump in the abdomen, no visible pulsation, there is no visible venous prominences, no scars, no fistula, no hernia detected on inspection. Palpation. The patient was afebrile to touch on the superficial palpation. No guarding, no rigidity present on the superficial palpation. Rebound tenderness sign was positive on the deep palpation. And McBurney sign was positive. No splenomegaly and no hepatomegaly found. Swas test was positive and no lump was palpable on the examination. Obturator sign negative. Roasting sign was negative. Now come on to the percussion. Abdomen is tympanic on percussion. Lever dullness starts at ends at the 6th intercostal space and the lever span was 12 centimeter. And there was no fluid thrill and shifting dullness. On auscultation, bowel sounds were normal, no brew heard. On miscellaneous, on DRE, there is local tenderness present. Now come on to the systemic examination. In head and neck, cranial nerves, no abnormality detected. In eye, pupillary reflexes, accommodation reflexes, conjunctiva were normal. In neck, no lymphadenopathy, no venous engorgement, no thyroid enlargement found. On chest examination, the chest is bilaterally symmetrical and the trachea was central in position. All quadrants move equally with the respiration. No added sounds were heard. On CVS examination, S1, S2 were normal, no added sounds were heard. On upper limb examination, no clubbing, no chylonychia, no joint abnormality heard, detected. Lower limb, no varicose vein, no joint abnormality detected. And the external genitalia were normal. Mehnaz?
Yes, am I audible? Hello.
Yeah, you're audible.
Okay. So moving on to the management, which is we'll first discuss the investigations in the case. So we generally see that there is an increase in WBC because of the inflammation. Okay, and then we also do urine examination to rule out if there's UTI or any sort of hematuria. And these two is because of the pain in the abdominal region. So there's no urine. The urine examination is quite normal. And we also see CRP is elevated. Okay, we also do plain X-ray to see if there's any sort of perforation or any abdominal obstruction. So and further we do CECT, which is contrast enhanced computed topography, which is also our investigation of choice. Okay, the next slide. The next slide. Yeah. So our final diagnosis is a 37-year-old male presenting with complications of abdominal pain in the right iliac fossa with anorexia, vomiting, and rebound tenderness. McBurney's sign positive and Saw's sign positive on examination. Localized tenderness on rectal examination is likely to be a case of acute appendicitis. Okay, without any clinical evidence of complications. Okay, so we, after all the procedures, we finally conclude that it is acute appendicitis. The next slide. So moving on to the treatment, what happens is when the patient comes with you with a lot of pain, we first admit the patient, and to relieve the patient, we give them
Mehnaz, are you there?
Very severe pain, we also give him electrolytes for any sort of correction. And we do take vitals, we monitor all his vitals, take care of him. And in the last, we give him IV antibiotics, which is our third gen cephalosporin, and metronidazole is also given. And after all of these, we take care of him. We take care of all the pre-surgical procedures, and we end up with the surgery, which is appendicectomy. The appendix is removed from the body, and we prefer laparoscopy over an open appendicectomy, which is better because it has less incisions and it is safer, and also causes less infections, because a open procedure leads to more infections. That's it. We come to the end. Thank you so much.
Thank you, team. Now over to the judges for questioning.
Okay. So to begin with, is the pain in the right iliac fossa itself or somewhere else to begin with in a patient with acute appendicitis? Usually.
It is in the right. It is in the right lower quadrant of the abdomen.
Or is it periumbilical?
No, right lower quadrant.
To begin
It's
with,
at the McBurney's point.
Yeah.
McBurney's point.
What is McBurney's point?
Yeah.
What is McBurney's point?
McBurney's point is the point in the right iliac fossa between the anterior superior iliac spine and umbilicus, 1/3 from the anterior superior iliac spine and 2/3 from the umbilicus.
Okay. So right from the beginning, the pain is usually in the right iliac fossa or the McBurney's point, or is it periumbilical? As far as I know,
McBurney's point.
to begin with, it is periumbilical. Okay, it is the referred pain that you have there, and later on the pain migrates to the right iliac fossa. Okay, so to begin with, it is periumbilical pain, which later on moves on or migrates onto the right iliac fossa or the McBurney's point. Okay, what is psoas sign?
Psoas sign is the sign seen by hyperextension of the right hip or flexion of the right hip against the resistance causes pain in the right iliac fossa.
Okay, and what is Roswing sign?
Roswing sign is the if we pressure on the left iliac fossa causing pain in the right iliac fossa. It's Roswing sign.
Okay. Okay. Over to Archana ma'am, if ma'am would like to add something onto this.
Yeah, see, they have given the differential diagnosis which the structures are not there in the right iliac fossa, like acute cholecystitis. How do you clinically say that there is acute cholecystitis? Which is the sign for the acute cholecystitis?
Jaundice, ma'am.
No, clinical sign. How will you examine? On examination.
Yellowish
Will be yellowish discoloration. He'll also have pain in the upper quadrant actually. But in the beginning, the patient comes with normal abdominal pain. That's the reason why we've put in this in the differential diagnosis.
Whatever the initial 3-4 diagnosis you had written in the slide, more than that, the lower 3-4 diagnoses are more closer than the upper distance. So the sequence should be different. Okay.
Yes, yes.
What are the complications of acute appendicitis?
Ma'am, there can be perforation of the appendicitis, where you also have to if there is infection because.
Hello.
Hello, ma'am. There is a rupture of the appendix, and there is a appendicular perforation, and ma'am, there can be appendicular.
So how will you clinically judge the patient has got a appendicular or lump and the rupture of the appendix? What will happen to his pulse? What will happen to vitals?
Ma'am, the patient will be in a shock,
Yes.
and there is a rigidity and tenderness.
Or both the things will be there, guarding as well as the rigidity. What will happen to the pulse?
Ma'am, pulse
decrease, ma'am.
Patient will be in tachycardia or bradycardia?
Initially tachycardia, ma'am.
Initial tachycardia.
Then it's bradycardia.
How do you know patient is having the complications? What will be the blood pressure?
When patient does not recover even after treatment, he become more toxic.
So even
Like,
looking at his saturation will be low, he will be having tachycardia, he will be tachypneic, having low blood pressure, hypotension. So these are the clinical
yeah, ma'am.
signs where you should look for, because it is an emergency for
Yeah,
any
ma'am.
surgical branch. Correct?
Yeah.
And any other presentation of acute appendicitis?
Mm,
Any other
It will
I
presentation?
mean,
is because of the chronic complications also. So they can present as a lump in abdomen. So if there is a
uh,
lump in abdomen, what would be the clinical features?
mm, and
I'm afraid
tenderness and uh, there's tender tender lump in the right iliac fossa.
Yeah.
there'll be tenderness, there'll be probably a bulge because of it showing outside.
So there will be the altered bowel habits also. Because
Hmm.
there is a bleeding, so there will not be the normal bowel movements.
Okay, ma'am.
Okay, nice. Good one.
Thank you, ma'am.
Yeah, thank you.
Any? Okay. Thank you, ma'am.
Judges, thank you dear for this wonderful performance. So now we will have a break of 10 minutes and after that we will again continue with the presentations. So yeah, we'll be dispersing for 10 minutes. Thank you.
Okay, welcome back everyone. So, welcome back again. And now we will be proceeding further. So the next group that will be presenting is group number 1. So group number 1, please take over, start presenting.
Hello, am I audible?
Yeah, you're audible.
Okay. So I'm Ibrahim Ilmi. I'm a final year student at Maulana Azad Medical College, Delhi. I will be presenting case 4 along with my teammates Anbubanan from MMC Chennai and Pritika from CGS Medical College. I'm presenting the case of Mrs. XYZ, a 39-year-old female, unmarried, 10 pass, and a resident of Saket who works in a poultry processing plant and belongs to the lower middle class according to the modified Swami scale. She presented presented to the Loknayak OPD on 31st October 2020 with chief complaints of cough for 6 months and shortness of breath for 6 months. She was apparently asymptomatic 6 months back when she experienced cough and shortness of breath. The cough was insidious in onset and progressive in nature. Initially, it was dry, but it has become productive over the last 2 months, with sputum being greenish yellow in color and viscous in consistency. It is sometimes accompanied by blood in sputum, once a day, bright red in color and mixed with the sputum. There is no seasonal or diurnal variation. There are no known aggravating factors, and there is mild relief on taking cough syrup. She experienced shortness of breath at about the same time, which was insidious in onset and non-progressive. She feels breathless on walking about 50 meters and has to stop frequently while walking. It is aggravated on physical exertion and relieved on rest. She has accompanying generalized weakness and has lost 7 kgs weight in the 6-month period. As for the negative history, there is no history of wheezing, no history suggestive of orthopnea, paroxysmal nocturnal dyspnea, chest pain, or palpitations, no history of recent international travel, no history of diarrhea or neck rigidity, no history of skin rash, ulceration, discoloration, or discharge, no history of swelling around the neck or elsewhere, no history of abdominal pain, mental disturbance, polydipsia, or polyuria. In the past 6 months back, she was hospitalized after she presented with cough, shortness of breath, fever with chills, GI disturbance, and headache. She was admitted for the same, and certain medications were given, nature of which she does not know. The fever and headache subsided soon, and she was discharged. She is a known case of rheumatoid arthritis, diagnosed 1 year back, for which she received oral and injectable medications, later identified as methotrexate, dexamethasone, and adalimumab. As for family and personal history, she is there's no history of hypertension, diabetes mellitus, tuberculosis, kidney disease, or liver disease in the family. She is vegetarian by diet. She does not consume alcohol or tobacco in any form. Bowel and bladder habits are unaltered. Sleep is unaffected, and she gets about 7 to 8 hours of sleep. As for my differences, in order of likelihood, I've kept it as tuberculosis, histoplasmosis, lung cancer, methotrexate pneumonitis, and NSIP. Now, this is simply based on history as of yet. Tuberculosis, the points that occur in favor are the fact that it has dry cough followed by hemoptysis. She is on adalimumab, that is a TNF alpha blocker therapy. She is immunosuppressed. Tuberculosis is ubiquitous in our country. She has weight loss and it is a chronic history. Histoplasmosis, although can mimic tuberculosis, however, there is no travel to endemic countries and it is far less common. Lung cancer, the points of cough and hemoptysis do support it, along with weight loss. However, she is relatively younger age, and there are no paraneoplastic symptoms. NSIP, yes, she does have dry cough initially, along with shortness of breath. However, the dyspnea is non-progressive in nature. She also happens to have an episode of fever and GI symptoms, and there is hemoptysis, which go against it.
Good evening, all. My name is Anbubanan. I'm a first-year medical student at Madras Medical College. I'll be presenting the findings of the physical examination. On general examination, the patient was conscious and oriented to time, person, and place. She was moderately nourished and built, and she weighed 50 kilograms. Her temperature was 98.4 degrees Fahrenheit, measured orally. Her blood pressure was 110 or 80 millimeters of mercury, measured in the right brachial artery. Her respiratory rate was 26 breaths per minute, and she showed a thoracoabdominal type of breathing. The pulse rate was 84 beats per minute, measured in the right radial artery, had good volume, normal underlying vessel, and there was no radioradial or radiofemoral delay. Her hair was black and not pluckable. And examining the eyes, the eyebrows, eyelashes, and eyelids were all normal. The lower palpebral conjunctiva appeared pale. Corneal reflex was intact, and pupils were equally reactive to light. She had normal vision. On examining the ears, the pinnae was symmetrical and freely mobile. There was no discharge observed, and she had normal hearing. On examining the mouth, her lips were pink and moist. She showed good dental hygiene. The buccal mucosa appeared pale. The dorsum of the tongue also appeared pale, and the uvula was in the midline. On examining the neck, there was no pain or discomfort in head movements. The cervical lymph nodes were not palpable, and the trachea was in the midline. On examining her skin showed normal texture. There was no pallor and no lesions or scars observed. Nails negative for clubbing. Posture, spine was vertically aligned, and she showed normal gait. Systemic examination. On inspection of the chest wall, it was bilaterally symmetrical. Respiratory rate was 26 breaths per minute, thoracoabdominal type of breathing. No accessory muscles were involved in the respiration. There were no skeletal deformities, wasting of muscles, engorged veins, scars, or sinuses observed. On palpation, the trachea was confirmed to be in the midline. The apical impulse was observed in the left fifth intercostal space, 1.25 centimeter medial to the midclavicular line. The chest wall moved equally on both sides over base and the apex of lungs. Chest wall expansion on full inspiration was 5 centimeters. There was no intercostal tenderness, and vocal femmitus was decreased bilaterally. On percussion, there was stony dullness over all the lung fields. In auscultation, bronchial breath sounds and fine crackles were heard over the upper chest bilaterally. Vocal resonance was also decreased bilaterally. On examination of the other systems, CVS, S1, S2 were heard, no abnormal heart sounds observed. All peripheral pulses felt equally on both sides. JVP not raised. On examining the CNS, the patient was conscious and oriented to time, person, and place, and there were no focal neurological deficits. On examining the abdomen, there were no nodules or masses observed. The abdomen was soft, no distension or organomegaly was seen.
Good morning. My name is Pritika and I will be taking on the management. So first, the investigations are for confirming diagnosis, staging the disease, and guiding treatment. For confirming the diagnosis, CBC, including hemoglobin, total leukocyte count, differential leukocyte count, and ESR will be taken, along with chest X-ray, sputum smear for AFB, tuberculin skin, and tuberculin skin test, which was negative. Now, staging the disease, CT lung is done, and interstitial infiltrates were seen. Along with this, sputum and blood culture on mycobacterial and other mediums, as well as CB-NAT and line probe assay are to be done. Finally, for guiding treatment, antibiotic sensitivity testing and liver enzymes need to be done. This was the image of CT lung, interstitial infiltrates. All right. Interstitial infiltrates with no lymph node enlargement and no bronchiectasis. Now, going back to our differential diagnosis, the points of miliary include therapy, weight loss history. However, the points also in our tuberculin test due to immunosuppressive interstitial infiltrates. Points against diagnosis are no skin lesion and no mediastinal lymph node enlargement. Lung cancer, the points against it are no endobrachial or peripheral tumor growth appreciated on CT. For non-specific interstitial pneumonitis, the point against is that there is no restriction to chest expansion. Finally, treatment. Combination drug, assuming it to be tuberculosis, a combination drug regimen for 2 months or till sputum negative, maximum 4 months. The intensive phase of isoniazid 5 mg per kg, rifampicin 10 mg per kg, pyrazinamide 25 mg per kg, and ethambutol 15 mg per kg. Streptomycin IM injection may also be required, 1 gram. This is followed by 4 months treatment with isoniazid, rifampicin, and ethambutol up to a maximum of 10 months. If drug resistance, treat according to antibiotic sensitivity. A final diagnosis, My patient, Miss XYZ, is a case of miliary tuberculosis, most likely due to reactivation following immunosuppression due to treatment of rheumatoid arthritis. Thank you.
Thank you, team. Now over to the judges for questioning. Archana ma'am, Rupali ma'am, fine.
How will you clinically diagnose miliary tuberculosis? Is it very difficult? It is very easy.
Ma'am, diagnosis of miliary TB is normally not done clinically. It should be done using a biopsy or with an X-ray or CT findings.
Only CT findings. Who does biopsy? Nobody does the biopsy. So it is a very difficult. And what is the new dots? Does it include streptomycin? It doesn't include now injectables.
Yes, ma'am.
Yes, ma'am.
So the categories have changed. So streptomycin is not
for primary. Yes.
Why not? It is a respiratory manifestation of rheumatoid arthritis, ILD.
Ma'am, in rheumatoid arthritis, there's usually NSIP that is more associated, and that will present with progressive dyspnea. And in this case, the dyspnea was static; it was not progressively worsening. Also, the patient also had hemoptysis, which is unlikely in NSIP, and she also had episodes of fever and GI disturbances, which again goes against that.
Okay.
And then on
So what
examination,
I
there were
feel
no
that other than going,
respirations.
okay, there were no. But it is very difficult to tell for you people also as a student up to the diagnosis is a miliary tuberculosis. Even I cannot diagnose a miliary tuberculosis. And if it is a miliary tuberculosis, what will get you will get? You will get a hepatosplenomegaly also because it is a hematogenous spread. Okay. Now, tell me some indications of steroids in a tuberculosis case. Which tuberculosis you give the steroids? You got my question?
Ma'am,
which
immune reconstitution syndrome and yeah.
No, in which cases of tuberculosis the treatment includes steroids?
Dermal and ocular tuberculosis.
Which manifestations of tuberculosis, ma'am is asking, can we use steroids for?
Lupus vulgaris.
Can I give you one example? In tuberculous meningitis, the steroids
Yes,
are indicated, yes, to prevent the adhesions. Similarly, miliary tuberculosis. So any other tuberculosis, you know, extrapulmonary tuberculosis where you have to give the steroids. Okay, fine.
Ma'am has just mentioned. So
Dr. Dupali, you can ask some questions.
So, okay, so you were saying it was due to treatment of rheumatoid arthritis, immunosuppression due to that has led to tuberculosis.
Yes, ma'am.
So which of these drugs is responsible? Which drugs?
Ma'am, adalimumab is a TNF alpha inhibitor, so that prevents the granuloma formation, and that prevents the containment of the tubercular focus.
So
And
how
that
can
can
that
lead
be
to
prevented? How can this complication be prevented? What should be done before you give these biologicals to a patient? What precautions must you must take?
ma'am, they should be screened for granulomatous diseases before they are started on
How will you screen?
adalimumab.
How will you screen for that?
That can be done by means of X-ray or by ACE enzyme levels, which can be elevated in tuberculosis.
ACE enzyme levels, sir? How would you reactive हुआ है ना तो latent TB rule out करना है. So how will you rule out that latent?
Tuberculin skin test would have been done before the treatment was
Okay.
started.
What other tests can you do other than tuberculin?
Interferon gamma release assay,
Okay.
quantiferon test.
A chest X-ray. Okay.
Yes, when chest X-ray was done.
Okay. So if any of these is suggestive of a latent tubercular infection, would you still like to give biological?
No, ma'am, because it would depend on the severity of the disease. Although biologicals can have a much more rapid action in containing the rheumatoid arthritis, however, if methotrexate plus sulfasalazine can be enough to manage, then they should be preferred.
Is there any way of treating latent tuberculosis? Do we treat latent tuberculosis?
No.
If your tuberculin test is positive, or if do we treat them? No.
No.
Okay. Thank you. Thank you. That will be all, I think, from my side.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you, team. That was wonderful. So now we will be moving on. So the next team that we have is Group 9. So Group 9, please join and start presenting. Group 9, are you ready?
Yeah,
Yes.
I think so. Our members having some difficulty. Give us a minute. We'll just see.
Hello, am I audible?
Sure. Yeah, you're audible.
Okay.
There is a difficulty to share this PDF.
Sorry?
Uh, Difficult. Amisha, can you share the PDF?
Yeah, 1 second. Is my screen visible?
Yeah, it's visible.
Okay, so good evening, everybody. My name is Amisha Wathodkar, and along with my group members Deepsha and Jinal Thakkar, we're going to present a case for the final round of Exquisite. So, our patient named Mrs. XYZ, age 32 years old, female, living in California, USA, and homemaker by occupation, and religion is XYZ, came with the chief complaints of productive cough, fever, and chest pains since the last 4 days, and shortness of breath since 1 day while walking around the house. Jinal?
Please change the slide.
Can you see the slide?
No, not yet.
Now?
No. Yes. So the patient was apparently asymptomatic before 4 days when she got continuous high-grade fever, which was remnant and with no chills. So the patient has a history of cough, which was insidious in onset, and it's progressive and with expectoration. It is moderate in amount and non-foul smelling. It is non-blood tinged, and it's of copious amount and purulent thick sputum. So the patient also complains of chest pain, which was around the sternum, and it is a pleuritic type of pain which increases on coughing and deep inspiration, and was for a short period of time. And there is a history of shortness of breath on walking around the house since 1 day, which was not associated with wheezing, or there was no orthopnea, and there's no paroxysmal dyspnea also. Next. So the physician prescribed her oral azithromycin, due to which the cough was diminished, but the chest pain and fever did not subside. And there is no other past history of jaundice or hypertension, diabetes, or other cardiac disease or lung diseases. There is no history of wheezing or sneezing or rhinitis. There's no history of dysphagia, hoarseness of voice, and stridor. There's no history of leg edema, and there's no history of close contact with tuberculosis. Next. Okay, so there's no history of smoking or occupational exposure. There is no history of travel, and the sleep, bowel, and bladder habits are also normal, and there's a normal appetite. Next. And there's no such significant family history of any allergic or asthma.
The examination was done with well-informed consent of the patient under broad daylight, and the patient was conscious and well-oriented to time, place, and person. So the patient is poorly built and with moderate nourishment, and the heart rate is 116 per minute. Blood pressure is 128 per 70 mmHg. Respiratory rate is 24 per minute, and the pulse oximetry showed a oxygen saturation of 94%. So the skin did not show any sign of pallor, and sclera did not show any icterus, and the nails also did not show signs of cyanosis or clubbing, and there was no lymphadenopathy or edema seen. And the temperature of the patient was 103.4 degree Fahrenheit. Okay, so the next thing will be described by Deep Shah. Thank you.
I am Deep Shah from GMRS Medical College Sola. I am intern at GMRS Medical Sola College. I am in this presentation. I am presenting the systemic examination. So in the systemic exam, first we have done the respiratory examination. The respiratory examination in the inspection, the chest is normal in shape and bilateral symmetrical. The respiration is regular, rhythmic, abdominothoracic type, and accessory muscle of respiration were normal, and the chest movement diminished at the left side. Um, um, uh, which is suggest that might be the pleural fluid there. On palpation, the trachea was deviated to the right side, the apex pit at the fifth intercostal space, and the system, it was a symmetrical expansion was seen on both sides, and the tenderness was seen at the left side of chest. Tactile vocal parameters is absent at the lower back side. Other side, on the other side of the lung, the upper middle lower zone, on the anterior and the posterior side, there were tactile vocal parameters was present. There was no sign of scar, dilated veins, and shininess of skin on the side to side of chest. Next slide. On percussion, on percussing the lung area, there is a dullness to the percussion on the halfway up at the lower lobe. On the rest of the lung, the upper middle lower zone, on the anterior and the posterior side, there was a resonant node which was normal. Only dullness was present only on the lower half, left halfway up at the lower left lobe posteriorly. On the auscultation, there was bronchial breath sound on the left side. Left side, the bronchial breath sound was heard, diminished in the left side infraaxillary. Decreased breath sound in the lower half of left lung. Few inspiratory crackles on the mid lung field were also heard. Her right side was clear with auscultation. Egophony is present. Abdominal examination. On abdominal examination, no lump, visible pulses or peristalsis present. No organomegaly palpable. On serious examination, heart rate was tachycardiac, but it was regular. All peripheral pulses are palpable and the arterial wall normal. Heart sound S1, S2 auscultated, and no additional sound were heard. CNS examination was not significant. So on the basis of this examination and sign and symptom, we have some differential diagnosis like congestive cardiac failure, which was due to, according to history of chest pain, fever, and cough. The pleural effusion due to history of breathlessness, cough, fever, left side chest pain, absence of breath sound on the lower half of the lung on the left side, and the parapneumatic effusion due to history of the fever, pleuritic chest pain, and the productive cough. Pneumonia due to history of fever, pleuritic chest pain, and productive cough, and also the breath sound which was decreased at the left lower side. And the pulmonary embolism due to acute chest pain and the breathlessness. There may be other differential diagnoses like cancer and diffuse pulmonary alveolar hemorrhage. On the investigation, we can do some. We have done some we can done some investigation like first we can take the history and the symptoms which are suggesting the imaging which can be done the, uh, after the blood test and the sputum done. On the imaging, we can do the CT scan, chest X-ray, anterior posteriorly, and the chest ultrasound also can be done. We can also do the thoracocentesis for the pleural effusion and parapneumatic infusion, and the fluoroscopy and the pleural biopsy also can be done for the malignancy if there is malignancy present due to pleural effusion. And the pleural fluid test also can be done for the pleural fluid effusion, and the Montauk's test is done for tuberculosis if any contact with person with tuberculosis. There was no history of death, but we can do for accurate diagnosis. Okay, and other test it is poor survival with low pH, low glucose, and high LDH, and carcinoembryonic antigen. On the pleural fluid examination, we can also have differential diagnosis according to transudate and exudate. Exudate is in that we can see the protein level, LDH level, cholesterol level, and the albumin level, and get diagnosis according to that. Emphysema does that is emphysema if there is presence of emphysema pus. So TB pleuritis for diagnosis of TB pleuritis, AFB smear and culture is also done. For fungal disease, KOH stain and culture also done. And other for chylomicrons, hemothorax, the PF upon blood ratio is greater than 0.5. The other investigation are pleural fluid analysis, which can show us different diagnosis according like bacterial, viral infection, parasitic infection. Then rheumatoid. Okay. So next slide. On exudates, if exudates are on the basis of the color of the exudates, we can have the different diagnosis like yellow green color show rheumatoid pleurisy, red color show pulmonary infarction, white color is chylothorax, brown chronic body, ruptured hemolytic liver abscess, urine shows urinothorax, water like uropleural fistula. Next slide. So there can be many infection based on exudates like bacterial, viral, as I talked before, bacterial, viral, fungal, and parasitic. And there is also can be connective tissue disorder.
You have only 3 minutes remaining.
Okay. Transudate, on the basis of exudate and transudate, there are many diseases which are shown here, like on the transudate have, if there is presence of transudate, so there can be congestive heart failure, hepatic hydrothorax, atelectasis, nephrotic syndrome, hypolipidemia. Next slide. So pleural fluid, glucose and pH also can show many differential diagnoses, and complicated parapneumatic effusion, it can lead to further disease. Next slide. Lymphatic predominance, if there is lymphatic lymphocyte predominance, so there are TB pleurisy, cryothorax, and other diseases. If eosinophilic predominance, so pneumothorax, hemothorax, pleural infarction. There is neutrophil predominance, so parapneumatic with infiltrate, pancreatitis, acute TB pleuritis, and if there is PF amylase, so acute pancreatitis, pancreatitis pseudocyst. Next slide. Next slide. Next slide.
Hello.
Hello. Next slide. Amisha. Hello. I can't see the next slide. So.
Hello.
Hello.
Yeah, Dean.
There is technical
it's fine.
problem.
It's fine. No problem because there is no need of all these things. You just tell me in your differential diagnosis why you are not put a pleural effusion as a first and why the congestive cardiac failure as a first.
Just to I was just changing that I was just getting assured that if there is no congestive cardiac failure, so I can directly point
So
on the pleural
in
effusion.
congestive cardiac failure, it is unilateral or bilateral effusion?
Congestive cardiac failure. Congestive cardiac failure.
Is it transudate or the exudate?
It is transudate.
Transudate. And
Yes.
actually, it is usually bilateral pleural effusion in all these transudative causes.
Yes.
Okay. So the and most commonest cause of effusion in India.
Common cause of effusion.
Pulmonary infection.
Tuberculosis.
Yes, tuberculosis.
What are the non-tuberculous causes of pleural effusion?
Can be pneumonia.
Pneumonia which is non-tuberculous. Okay. The other pneumonia. Any other?
Infection, any infection, bacterial, viral, parasitic, or bacterial, viral, parasitic infection.
Besides
Or
infection, any other cause of pleural effusion?
any tumor which can lead to pleural effusion.
You have so much of the list of transudative causes. So they are all non-tuberculous causes. Nah?
Nephrotic syndrome.
Yes.
Then cirrhosis.
Yes.
Cardiac disease, CHD, congestive heart failure.
Congestive cardiac failures.
Peak syndrome.
Rheumatic diseases. Rheumatic
Yes,
factor.
collagen vascular diseases causing the respiratory involvement. What is mixed syndrome?
Sorry, ma'am.
Mixed syndrome.
Mixed syndrome. Mixed syndrome is ovarian tumor. It also leads to pleural effusion.
What is your first diagnosis in your case? The pleural effusion, na?
Yes.
Yes.
Which
Yes.
side, right or left side?
Left side.
Left side pleural effusion
So
at the lower.
on percussion on the left side, what will you get if there is a left side pleural effusion? What happens to top space?
In the top space there will be on auscultation we can't hear the breath sounds properly there.
No, what is the top space? What are the boundaries of top space?
Boundaries of top space are mid spine level, medially mid spine level, and at the uh, it spread until there is effusion at the lower side.
It is obliteration of the drop space and it is a quadrangular space. It is not a triangular. So that is important for you. Otherwise, it is difficult on the left side pleural effusion how to diagnose clinically. There is obliteration of the drop space. Similarly, on the right side, you will get a tidal percussion which is positive. These are the two things which are important for you people at your level to demonstrate when you are going to demonstrate the signs. I think from my side, it's okay, Dr. Rupali.
What is Guruko's triangle of dullness? Have you heard of this? In a patient with pleural effusion, where do you find this triangle of dullness on percussion?
Protocol is present posteriorly, where the breath sound are not heard properly.
Okay. One thing.
And medially mid spine.
Okay, what are the limitations of percussion? What are the limitations of percussion?
Limitation of I mean the placing of percussion or
what kinds of pathologies you will not be able to find even if they are there on percussion? When will you not be able to find a pathology?
okay, so limitation are when there is any infection we can
How much fluid should be there at least so that you can clinically?
500 ml fluid should be at least there for finding of pleural effusion.
Okay. Clinically also 500 ml? Okay. And what is the importance of doing tidal percussion? Why should we be doing tidal percussion? Ma'am was just mentioning regarding tidal percussion. Why should we be doing tidal percussion? If you have a right-sided effusion, what is the importance of doing tidal percussion? What is tidal percussion?
Tiger percussion is don't you mention to place the boundary of that pleural effusion, so we can draw we can mark that place as a mark the boundary of the pleural effusion.
What do you mark in tidal percussion? What do you right?
By target percussion, we can see where there is a dull note is present, so we can mark that side where the pleural effusion is situated exactly.
Any other one in your group? Would you like to answer on that? What is tidal percussion? What is the importance of doing liver dullness when we do percussion? Yeah.
Liver dullness. For the stony dullness, if there is a stony dullness, for the stony dullness, if there is a stony dullness is present.
In your examination, you have mentioned dullness, and then on the other side, on auscultation, you have mentioned bronchial breathing. Is it possible when you have? Is it possible to have bronchial breathing with fluid? Even if it is a pneumonic effusion, will you be able to hear bronchial breathing? Is it possible?
Breathing is bronchial breathing because pleural effusion usually have bronchial breathing due to.
Where will you have bronchial breathing, if at all you will have? Throughout?
On the side of effusion.
Throughout, you will have bronchial breathing?
No. On the that side of which side have effusion?
In the entire lung, where will you have?
Where the effusion is present.
Okay, where effusion is present, you have bronchial breathing.
Yes.
Any one of you would like to comment on that? Any other?
In the tracheobronchial tree.
Okay. Okay, ma'am, anything else would you like to ask, Karshna ma'am?
No, it's okay, fine.
Okay, chalo. Thank you so much, guys.
Yeah, thank you.
Thank you, judges. Thank you, team. So now we will proceed further. We have group number 5 presenting ahead. So group number 5, please come aboard and start your presentation.
Good morning. We are group number 5, presenting case number 7. I'm Siddharth Pira from Gandhi Medical College. I'm a final year student, and my partners will be introducing themselves right now.
Good evening, everyone. This is Rupesh, Gandhi Medical College.
Hi, everybody. I'm Siddesh. I'm from MGM Medical College.
Okay, so I'll be starting the case. We have been given one of the most important cases in the medical emergency wards. I'll be crisp, I'll be goal-oriented, and without boring you with balls of text, I'll begin now. So we got a patient, an 18-year-old female, going by the name Quadruple X, a resident of Hyderabad and a student by occupation, who was brought to the emergency department by her mother. The patient complained, the mother gave a history of abdominal pain, which was present since morning. The patient was confused and behaving strangely since morning, in the mother's words. The mother also gave information regarding a weight loss, which was around 20 pounds in weight since the past 2 to 3 weeks, fatigue for the last 2 to 3 weeks, and sleep disturbance for the last 2 to 3 weeks. The mother also reports that the patient has always been healthy. Patient has lost 20 pounds of weight without any effort, and has been complaining of fatigue for the last 2 to 3 weeks. And patient has attributed the fatigue to just a second. Yes, the patient has attributed the fatigue to sleep disturbance. She has been getting up several times in the night to urinate. This morning, the mother found the child in the room complaining of sudden onset abdominal pain, which was diffuse in nature and not radiating, with no aggravating or relieving factors, no headache, and no shortness of breath. The patient also had a single episode of vomiting this morning. The patient appeared confused and did not know that it was her school day. No history suggestive of infection in the recent past was present. So with the history of presenting illness, we have been able to localize the compartment to probably the central nervous system or to an overall systemic metabolic pathology. Two possible systems that could be affected were the CVS and renal system. Further history and examination reveals more information. There was no significant past history and no history of usage of medication in the patient. The patient did complain of sleep disturbance, an increased frequency of urination, and no history of drug abuse. The patient was not habituated to smoking and drinking alcohol. There was no significant family history. The pertinent negative history were no history of drug abuse or over-the-counter drug consumption or consumption of any prescription drugs. There was no history of intake of alcohol, or there was no history of fever. The history of urination and the sudden loss of weight, along with confusion, made us go towards a diagnosis of diabetic ketoacidosis or a possible non-ketotic hyperosmolar coma. Since diabetic ketoacidosis has metabolic acidosis along with it, there is there's higher incidence of abdominal pain, which makes us lean more towards diabetic ketoacidosis. Differential diagnoses which were ruled out based on the history were alcoholic ketoacidosis because there was no consumption of alcohol. There is no starvation ketoacidosis because the patient reported no previous attempts at starvation. There was no anion gap metabolic acidosis due to because we also noted that there was no other prescription drugs or any drug abuse going on. Metabolic encephalopathy was ruled out due to no other systemic illnesses or fever which the patient presented with. The probable differentials were diabetic ketoacidosis and non-ketotic hyperosmolar coma, both present with CNS manifestations such as confusion, but metabolic acidosis component suggested by abdominal pain makes us go towards the diabetic ketoacidosis diagnosis. Further, the examination findings will be discussed by my partner.
So the patient was in supine position, conscious, incoherent, and cooperative. Patient was examined in the presence of a female nurse. The patient is poorly nourished and thinly built. The patient was lying on the stretcher, eyes closed, and responsive to the questions. Patient was observable, and head-to-toe examination appeared to be normal. So coming to the vitals, the heart rate was 118 beats per minute. And on standing, it rose to 145 beats per minute. The pulse was regular and thready. Vessel wall condition was normal, and there was no radial or radiofemoral delay. The blood pressure was 125/84 millimeters of mercury, and on standing, it fell to 110/80. The respiratory rate was 24 per minute, and as mentioned before, the patient was self-eval. So the common signs were looked for, like pallor, icterus, cyanosis, clubbing, koilonychia, lymphadenopathy, edema, and all of them were absent. The eye was normal on fundoscopy, and the oral mucosa was dry. Upon systemic examination, it was observed that the chest is clear to auscultation. It was tachycardic with a regular rhythm and no murmurs. Upon examination of abdomen, it was soft, active bowel sounds were heard. It was mild. There was mild diffuse tenderness present, and there was no guarding or rebound. And neurological examination reveals no. Coming to the investigation, so the serum, different laboratory findings were taken into account. The serum sodium was 131 milligauss per liter. Potassium was 5.3, chloride 95. The blood urea nitric was 35 mg per dl. The creatinine was 1.3 mg per dl. The glucose was 475 mg per dl. The PCO2 was 24 millimeters of mercury, and the PO2 was 95 millimeters of mercury. The urine drug screen and urine pregnancy test both came back negative. Upon urine analysis, there was no hematuria, no pyuria, and there was presence of glucose and ketones. And the chest X-ray was normal, abdominal X-ray plain film, no non-specific gas pattern, and no signs of obstruction. On the infection screen, blood and urine culture, C-reactive protein, the complete blood picture revealed leukocytosis.
Hello, I would like to continue with management. In the first hour of presentation, I will assess airway, breathing, and circulation, and establish IV access, preferably two peripheral IV lines, one for saline infusion, which is the main stay of treatment in this patient, and the other for other for insulin infusion, and also draw samples and send for laboratory investigations. Commence 0.9% sodium chloride, 1 liter over 60 minutes. Commence 50 units of human soluble insulin in 50 ml, 0.9% sodium chloride, infused intravenously at 0.1 unit per kg body weight per hour. Monitoring of capillary blood glucose, ketone testing, venous bicarbonate, and potassium after 1 and 2 hours, and then every 2 and 6 hours. Plasma electrolytes are tested every 4 hours. Monitoring of O2 saturation, pulse, blood pressure, respiratory rate, and urine output every hour. In the next 6 hours, I will continue with saline infusion and potassium infusion if needed based on plasma potassium concentration. And overall saline infusion is summarized as 1 liter of infusion over 2 hours, and 1 liter over next 2 hours, and 1 liter over next 4 hours, and 1 liter over next 4 hours, and 1 liter over 6 hours. Total 6 liters of saline infusion. And we can add 10% glucose at 125 ml per hour IV when glucose concentration is less than 250 milligrams per deciliter. If plasma sodium is more than 155 milliequivalent per liter, 0.45% sodium chloride can be used. Potassium chloride infusion is to prevent hypokalemia, which can occur because of insulin infusion. We can add one ampule of potassium chloride is 10 ml can be added for 1 liter of normal saline, which corrects 20 milliequivalents of potassium. If plasma potassium in millimoles per liter is more than 5.5, no correction is required. If it is between 3.5 to 5.5, 20 millimoles per liter of infused fluid is required. If it is less than 3.5, 40 millimoles per liter of infused fluid is required. In the next 6 hours, continue IV fluid replacement and continue insulin administration, and monitor clinical status, glucose, plasma glucose, ketonemia, acidosis, which should be improving by then. Avoid hypoglycemia and check for the signs of fluid overload like heart failure and cerebral edema. In the next 2 hours, by 24 hours, ketonemia and acidosis should have resolved. If patient is not eating and drinking, continue IV insulin at low rate of 2 to 3 units per hour. Continue IV fluid replacement. If ketosis is resolved and patient is able to eat and drink, subcutaneous insulin is overlapped, which is continued later. When subcutaneous insulin is started, we should not abruptly stop IV insulin. At first, we have to overlap subcutaneous insulin with IV insulin, which is continued later. My final diagnosis is type 1 diabetes mellitus with ketoacidosis without complications. Summary, please. An 18-year-old female presenting to emergency with altered sensorium and abdominal pain and an episode of vomiting. She has a recent history of weight loss and increased frequency of micturition at night. On examination, the patient was tachycardic and features of volume depletion such as dry oral mucosa. My final diagnosis is type 1 diabetes mellitus with ketoacidosis without any complications. Thank you.
Thank you, team. Now,
this is a complication of a diabetes, na? Type 1. So you should not say without any complication. Actually, this is the first time the type 1 diabetes has come with the metabolic acidosis. What are the other causes of metabolic acidosis?
You have a starvation ketoacidosis, alcohol-induced. Then you have a catecholamine stress response. You have a metabolic encephalopathies. You have high anion gap metabolic acidosis. due to causes such as salicylate poisoning, methanol poisoning, ethylene glycol poisoning.
Okay. So how will you test for the bedside test? What is this? What is the first investigation you should send rather than giving the list of the investigation?
First investigation on bedside, you can do a glucose dipstick and you can do a ketone dipstick. Ideally, you should be immediately you should set in for electrolyte status.
No, only one ABG.
Yes,
ABG, it's
ABG.
extended ABG
Yes.
will tell you.
Yes.
Okay. How common is the type 1 diabetes? What is the classification of diabetes?
So type 1 diabetes is classified into 4 types of diabetes. You have actually 5. You have type 1 diabetes, type 2, type 3, and type 4. Type 1, there is even a type 1.5 diabetes, which is of 2 types. You have LADA and KPD.
Yes.
Type 1 diabetes is generally due to, you have it in a young onset, like the patient is relatively younger without any autoimmune stigmata, whereas type 2, you have autoimmune stigmata and the patient is slightly older with features of obesity and insulin resistance. Type 3 is generally associated with Alzheimer's. Ketone predominant diabetes is a type 1 diabetes, type 2 diabetes patient presenting early with diabetic ketoacidosis, which is relatively uncommon. Whereas LADA is a type 1 diabetes patient who's presenting really late in his life.
Okay. LADA can be a type 2 also.
Yes, LADA can be either type 1 or type 2. And
So
along with that, yes.
What is the investigation you send for the type 1 diabetes?
Type 1 diabetes.
Insulin.
Investigation. Which levels are important?
Autoimmune.
No, type 1, you have both insulin, C-peptide and insulin levels.
C-peptide levels.
Yes.
So it will be low C-peptide.
Low C-peptide levels. So you can differentiate between giving exogenous insulin, type 2 diabetes, and type 1 diabetes.
If I tell you ki you do the X-ray abdomen for this patient,
yes.
You will laugh at me or you will agree with me?
X-ray abdomen and chest would be beneficial because these patients have a predominant of going into non-cardiogenic pulmonary edema.
No, I'm just asking only X-ray plain abdomen standing in type 1 diabetes. What you will see at L2 level on the left side, calcification.
Okay. The patient, like these patients, even acute pancreatitis episode can.
Because if it is a diabetes due to the pancreatitis,
yes,
you will get a pancreatic calcification. So
yes.
that is the importance of the X-ray plain abdomen.
Yes.
Okay. Dr. Rupali?
Okay, so how will you differentiate between MODY and type 1 diabetes? What is MODY?
MODY is what happens is that's a genetic diabetes syndrome where you have a gene mutation in the hepatic factor. So over here, what's going to happen is you're going to have 3 generations of diabetes, like family history of 3 generations having diabetes at a really young age.
Why should they have that family history? Because what is the mode of inheritance for MODY?
It is an autosomal dominant mode of inheritance.
Can it present with DKA?
Generally, it does not. It has a relatively good prognosis and does not present with DKA commonly.
Important. Okay, so it will not present with DKA.
Yes.
Type 1 usually present with DKA. What is the dominant ketone body that the patients of DKA have?
Beta hydroxybutyrate.
Generally, we are testing beta hydroxybutyrate is not available in biochemical tests. So we have a special test known as Hans test for it. So beta hydroxybutyrate values are elevated. So if you just do a normal Rotheras test, you might get a false negative of ketone body absence. So a Hans test is done because beta hydroxybutyrate is elevated to a higher level compared to the other ketone bodies.
Which ketone body will it test? Urinary ketone dipstick test?
Urine dipstick. Pardon me?
Which ketone body is tested on the urinary dipstick test? Beta hydroxybutyrate you will not be able to test on the urinary test. The test.
Hello. Yes. It tests acetoacetate in the urine.
Okay. So during reversal of acidosis, do we expect the levels of acetoacetate to rise?
I'm not really sure.
Yes, can I answer this?
Yes, sure.
As DKA is corrected, beta hydroxybutyrate is converted to acetoacetate.
Yes.
So acetoacetate,
So urinary dipstick can show increase in the ketone levels.
Yes.
Okay. Yeah. While you are having reversal. So ABG is important. So we are supposed to look at the acidosis correction in the blood as well. Okay. Yes. And why should we add potassium, KCl, with insulin infusion?
Generally, insulin causes a like a shift in the potassium levels into the intracellular compartment. So you suddenly get a extracellular decrease in the levels of potassium. So we add KCl to counterbalance this. And as the patient is recovering, we start tapering down the KCl because the effects start shifting. The same is seen with sodium, which has an inverse relationship with glucose. So we monitor sodium and potassium simultaneously during this entire process in order to avoid any metabolic electrolyte disturbances.
Okay, fine. I think rest all you have already covered. So thank you so much.
Thank you. Thank you.
Well presented.
Thank you.
Thank you.
Thank you, judges. Thank you, team. Well done. So now moving on, we have finally come to the last team, that is the participant. Now we will have group number 7. So group number 7, please join and present your screen.
Yes. First of all, a very good evening. Am I audible?
Yeah,
Am I
you're
audible?
audible.
Yes. First of all, a very good evening, respected judges, moderators, and all my fellow participants. We are. My name is Danish Gandhi, and I'm from HPTMC Cooper, Bombay. And my partner is Ms. Arzu Gupta from MAMC. We have a case on psychiatry, and it is the last case. So I don't think the interest levels will be very high, but we promise that we will indeed give it your time's worth. So without further ado, I would now request my colleague, Ms. Arzu Gupta, to start with the case presentation. Just a minute, I'll start screen share.
Good evening, professors. Am I audible?
Yes, you're audible.
I am Arzu from Maulana Azad Medical College, New Delhi, final year student. I'll be presenting the history part. Yeah, next slide. So we are presenting the case of Miss Reva Gupta, a 34-year-old Hindu, right-handed female, resident of 32B Karkar, Duma, Delhi, upper middle class according to modified Kuppuswamy scale, and is graduate and works as a data analyst at Reliance, Delhi. The telephone number is given. She is single and lives with her mother near the hospital. The patient was brought to the hospital by her mother, and the history was given by the patient and her mother and seems to be reliable. She was feeling restless since 3 weeks and was acting absurd and behaving wildly since 3 weeks. So for your ease, we have given a timeline of her disease progression. She was apparently normal 3 months back when she started having symptoms of depression since 1 month, and she was started on capsule fluoxetine for 3 weeks, and she was assessed later on. So there was a partial resolution of her symptoms. So the dose of fluoxetine was increased, and after 3 weeks, she presented with a current episode of drug-induced mania-like symptoms. So the patient was apparently well 3 months back when she started feeling fearful with low self-esteem, gained weight, was having sense of worthlessness, inability to sleep, suicidal thoughts, and despair. She was kept on tablet fluoxetine and was re-evaluated after 3 weeks, and she responded to them, but not all her complaints vanished. So the dose was increased, and 3 weeks later, she started feeling joyous. She then started thinking of herself and started worrying that her head may lit up due to the heat, heat of thinking too much, and starting wrapping her head in wet towels. She started medicating herself with amphetamine and cannabis and thought herself to be more intelligent than Albert Einstein. She started getting suspicious about everything and started calling her colleagues for marriage as her sex drive was very high. She was thinking too high of herself and believed she was God and was restless all the time. She had a tendency to describe herself out of the bounds. She started acting wildly and was brought to the hospital again by her mother. There is no history of alcohol abuse, drug dependence, apart from occasional cannabis and amphetamine use, no history of tolerance, craving, or inability to control substance taking behavior. There is no history of diabetes, hypertension, seizures, or asthma, and no history of any persecutory delusions or auditory hallucinations. There's no history of similar or any other psychiatric illness in the past. There's no history of major emotional trauma or mental trauma in the past. So coming to the personal history, the patient consumes cannabis around 2 to 3 times a week. Since past 1 month, she admits feeling euphoria after taking it. There's no history of flashbacks or reduced motivation or extreme rage are associated with cannabis use. She started consuming amphetamine in the form of tablets 2 to 3 times a week. since the past 1 month and admits feeling increased mental activity after taking it. However, patient denies any symptoms of physical or psychological dependence to any of the two drugs. She is right-handed and a vegetarian person. Bowel habits are altered since she started taking antidepressants with occasional constipation and diarrhea. Sleep is reduced as says she doesn't feel the need to sleep. She has very high energy levels and is having problems at work as she is unable to concentrate properly. Her mother reports that her appetite has increased in the last 3 months. Family history: she is currently living with her mother as her father expired when she was 20 years old. She has no siblings. There's no history of any psychiatric illness or substance use disorder in the family. So, thank you. My partner will continue here on.
Thank you, Arzu. I'll be continuing with the examination. Coming to the general examination, patient is conscious, cooperative, well-oriented to time, place, and person. Weight is 78 kgs, height is 5 feet 2 inches. BMI is calculated to be 31.64. That comes obese and with a picnic body type. She's afebrile, pulse is 76 beats per minute, regular, good volume. Respiratory rate 16 cycles per second. Blood pressure is 130 by 80. Examine right brachial artery in supine position. No evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Coming to the heart of any psychiatric case, you guessed it right, it is the mental status examination. Interview was conducted in English in the presence of the patient and her mother. Patient was conscious, cooperative, well-oriented to time, place, and person, and is well aroused. Good rapport were established with the patient and her mother. The patient is extravagantly dressed with blue goggles, orange shoes, and yellow pants. She has a picnic body type. She is well groomed and has good facial expressions. Motor behavior is remarkable for increased restlessness and fidgeting. She is constantly trying to balance a pen on its tip. Attention and concentration is reduced, assessed by serial counting backwards of 100 minus 7. Recent past as well as remote memory is intact. Speech is fast, copious, difficult to interpret, heavy, with clang associations. Patient has grandiose delusions that she is more intelligent than Albert Einstein. There is no evidence of thought insertion, withdrawal, or broadcast. Patient does not have any auditory hallucinations or persecutory delusions. Mood and affect. Quality of mood is that of exaltation. She feels excessively happy without reason, with increased psychomotor activity, along with grandiose ideas. She also gets irritated and angry easily. That is dysphoria. Further, the mother reports that her mood changes within a span of a few minutes. That is, emotional lability is present. Affect, however, is congruent with the mood. The patient feels that her head may lit up due to thinking a lot and hence wraps her head in cold towels, suggested of synesthetic hallucinations. No evidence of any auditory or visual hallucinations, no history of illusions. Insight is absent as patient denies existence of any illness, that is grade 1 insight. Systemic examination, CNS examination is normal. Respiratory system, air entry is bilaterally equal, no adventitious sounds are heard. CVS, S1, S2 are normal, no murmurs. Abdominal examination reveals no abnormalities. Coming to differential diagnosis, I would first like to give the differential diagnosis of a bipolar disorder, type 3 bipolar disorder with current episode of mania, and second one being a schizoaffective disorder. Coming to the final diagnosis, the patient is suffering from type 3 bipolar affective disorder. Type 3 is because of SSRI drug treatment for depression, which then switches over to mania. The patient is suffering from type 3 bipolar affective disorder, currently in drug-induced mania, with psychotic symptoms and substance use disorder, with total duration of illness since 3 months and duration of present episode being 3 weeks, and has no significant family history. Coming to the management of this patient, since he is in acute manic phase, we have to give an antipsychotic. We'll prefer an atypical antipsychotic since it has a better side effect profile, which is also the drug of choice for acute mania. We will also start mood stabilizer therapy as well as benzodiazepines. These 3 drugs will be continued for a period of 1 to 2 months. by which we should then enter the stabilization phase. During this phase, we have to continue the mood stabilizer and gradually taper off the remaining 2 drugs. Stabilization phase usually lasts for 3 to 4 months, after which the patient enters the stable phase, wherein we will do away with the antipsychotics and benzodiazepines and continue the mood stabilizers to prevent the relapse. So currently, if this patient comes in my OPD, I will give a starter on lithium, tablet lithium, 900 milligram twice daily, orally for 1 month. Tablet risperidone, which is an atypical antipsychotic, 2 milligrams 3 times a day for 3 weeks. Tablet lorazepam, which is a benzodiazepine, 0.5 milligram once a day for 3 weeks. This comprises the pharmacological therapy. In psychiatry, we should also consider non-pharmacological or psychotherapies, which in case of mania or bipolar disorder is that of psychoeducation. What exactly is psychoeducation? It means educating the patient regarding the psychiatric illness. It's as simple as that. Educating a patient and its family members. You have to inform them about the illness she has, about what is the cause of the illness, what are the outcomes available, from what is the prognosis, and what is the importance of taking medications regularly, what are the harms associated with mania, etc. Why are we doing this? This is to ensure better compliance to the treatment, and the patient continues the treatment till it's required. We will also call the patient to revisit after 1 month. So yes, that concludes the management part. Not as much as the other cases. And I would like to thank you all for a patient hearing, and we'll be more than happy to answer any questions. Thank you.
Hello, all 3 of you have presented very well. It is some
Ma'am,
different case.
It's not 3 of us, it's only 2.
Acha, 2 only? Okay, sorry,
Yeah.
sorry.
Yeah.
But it was very well presented. It is
Thank
a
you, ma'am.
difficult case and different from the others.
Yes.
So difficult for us to give the points as per the what rules and regulations. In the sense, your systemic examination was very small, na?
Yeah, we focus
But
more
you
on.
are having a good psychiatry history, and psychiatry that is more important. So we will definitely adjust that. That is good. So according to you, this is a drug induced, or what you call type 3 is
Yeah.
because of the drug induced?
Yes, ma'am. So, ma'am, in bipolar disorder, we have a classification of type 1, type 2, and type 3.
Yeah.
Now, type 1 is if there is presence of mania. Any time during the illness, it comes into type 1. If it's not full-fledged mania, but if it's hypomania, that is a milder form of mania, it comes from type 2. Type 3 is a special form wherein what happens is that a patient presents with depression, gets treated with antidepressants, and then converts into mania. So that is a special form. That is a special form, type 3 bipolar disorder.
Yes, you are right.
Yes, ma'am.
Any other side effects of these major or antidepressant drugs? What you should monitor?
Yes,
Now,
yes, ma'am.
for the SSRIs, the immediate side effects are mostly associated with GI symptoms like nausea and vomiting. They are also associated with weight gain. And for long-term side effects, they have sexual side effects like delayed ejaculations, which is mostly treated by buspirones and cyproheptadine type of drugs.
Any cardiac side effect? What
Yes,
you should
ma'am.
monitor?
Yes, ma'am. These antidepressants cause QTC prolongation,
Yes.
predisposing the patient to develop torsades de pointes. Hence, we should monitor the QTC interval.
Yeah, because it is very dangerous to keep the patient alone.
Yes.
You can get one news ki patient is not responding. So
Yes.
we don't know, some arrhythmias also can occur.
Yes.
And these patients, they are more likely to take a overdose also if they
Yes.
feel
For a suicide attempt.
better.
Yeah. Yes.
That is why. So it is very dangerous drugs. But
Yes.
under monitor, you should. The psychoeducation is the most important. That is the counseling part.
Yes.
So as you also rightly said, not the management is not like the other cases. It is a
Yeah.
different types of the management. So we will
Yes.
definitely
Yes.
keep in that mind. Your way of treating the patient is a different. It is not only
Yes.
the medication. The psychoeducation or the counseling is very, very, very important. And nowadays also, because of all the things which are going on around,
Of course.
so these things
Psychiatry
are
is extremely
increasing.
important.
So
Yes, ma'am.
good.
Thank you, ma'am. Thank you.
Dr. Rupali?
Extremely well presented
Thank you, ma'am. Thank
Thank
you.
you so much, ma'am.
The only question I had was the types of bipolar disorders which you have also
Oh.
mentioned. And one thing is like side effects of lithium. Can you tell
Yes,
me
ma'am.
regarding some side effects of
Yes, yes, ma'am. So, ma'am, side effects of lithium can broadly be divided into three categories. One are the neurological side effects, the endocrine side effects, and the renal side effects. Also, other miscellaneous side effects, which I'll come to later. Starting with neurological side effects, they cause tremors, postural tremors. The earliest tremor to appear is actually a tongue tremor, like that. They have patients have a cognitive decline in the form of a lack of spontaneity. Further, they are notorious to cause thyroid abnormalities. Hypothyroid as well as hyperthyroid can occur. Hence, if a patient is on long-term lithium therapy, it is imperative to monitor the TSH levels. Coming to renal side effects, lithium can cause polyuria, which is due to a nephrogenic type of diabetes insipidus. Management of that is by thiazide diuretics. Miscellaneous side effects include things like acne, psoriasis, and yes, during pregnancy, if a patient inadvertently takes lithium during pregnancy, it is teratogenic and can result in formation of
It's really normal.
Epstein's anomaly of the fetus, which
It
is
can also cause neutrophilia.
yes,
Any
it
effect
causes,
on calcium, PTH or calcium?
yes, it causes hyperparathyroidism.
Okay. And you said the nephrogenic diabetes insipidus is to be treated by thiazide diuretics. How do those drugs help there?
Yes.
They're diuretics.
Yes. So they have a paradoxical role over actually. So what is postulated is that by causing diuresis, they increase the sensitivity of the PCT, so that absorbs more of the water and electrolytes, thereby balancing of the
Can
polyuria.
the loop diuretics have this effect?
Uh,
No, because the
treatment-induced nephrogenic diabetes insipidus, we specifically use amiloride.
yes, ENaC inhibitors. ENaC inhibitors. Yes.
Why? How does it help? Because lithium uses the sodium channels only to enter the cell.
Yes.
This amiloride, which is specifically used for lithium-induced nephrogenic diabetes insipidus rather than the thiazide diuretics.
Yes.
Loop diuretics, why are they not helpful like the thiazide diuretics? Any idea?
They are on NKCC channel. So
thing is the
and one more thing over there will be the loop diuretics will cause increased delivery of sodium to the thiazide diuretics. So increased delivery of sodium to the DCT. So along with more sodium, more lithium will also get reabsorbed.
Thing is the loop diuretics they are the high ceiling diuretics, so they have brisk onset and for a short duration. Whereas these thiazide type of diuretics, they're low ceiling diuretics, so the plasma volume contraction which they cause is much more. That is why you will have less delivery to the PCT, so that it will absorb less and then less will be excreted. Okay, so
yes,
thiazides which are useful, but for lithium induced it is amiloride which is useful.
Yes, ma'am. Yes.
Okay,
yes.
fine. Okay, so that will be all from my side. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Have a nice.
Very nice.
I had a nice time with Dr. Archana, ma'am. It was a learning.
Yeah, because we had a very first time good experience. Yes, it's very good.
I really realized that it should be basic for the undergrad students. It has to be something basic.
Correct.
So, thank you so much,
It's
ma'am.
good, but at least we also learned something. Because the psychiatric case is little difficult.
It was nice, but you guys really presented it well.
Thank you so much, ma'am. Thank you. We appreciate it, ma'am. Thank you.
Good luck to all of you.
Thank you. Have a nice.
Best.
So thank you so much for educating us with such an informative presentation. And as we have come to the end, we would like to have the score sheets. So judges, please forward us the score sheets. And till we
So we will
calculate,
put
we
in
would
the
like
same
our
group.
judges to speak a few words.
Dr.
Yes,
Shreya, we should put in the same group?
Yes, ma'am.
Or you want a personal? Same group?
Yes, ma'am.
We will put the score.
Yes, ma'am. You can send the results on the same group, and the moderators will calculate the scores and announce
No
the
issue.
winner.
Yeah.
Yes.
Thank you so much. Thank you, ma'am, and thank you all the
Please,
audience.
ma'am, please stay
thank
on
you,
the
Dr.
call
Rupali.
because we'll be announcing.
Best of luck to everyone. Stay safe.
Please stay back.
Ma'am, please stay back.
Yeah, sure. Okay. Take care, guys.
What happened?
We would like you to speak a few words.
Call, because we would want you to stay when the results are being
announced. And also, we would love if you all, could share your experience, like, how,
Photo button. Yeah, group for it.
and, we would love to hear from both of you.
Okay, sure. So you can just do the totaling meanwhile. We'll just send you the results across, okay?
Yes, ma'am. You can send the results and then we'll calculate.
लवकर पहिला पाठवा पहिले.
Love participants' feedback on today's event, so we can discuss that while the scores are being totaled.
So the scores are getting, you guys are totaling the scores, right?
Yeah. Then still we can
Calculate the, yeah. So
Yeah.
till then we can like have a little bit, a small discussion. How was everyone's experience? Firstly,
Avantika, you can help from, one second, Shivani. Avantika, you can take help from Shreya also, and you all can like divide so that, it will be quicker.
It's fine. We both are doing it. It's totally
Okay. Okay, fine.
So, okay, firstly, I would like to introduce myself. So, my name is Shivani Golap, and I'm the co-founder and the chief executive head here at Clinicase. And along with me, I have Akatya Vidushi. She's also the co-founder and the chief executive head here at Clinicase. So, firstly, congratulations everyone for coming to this final round and qualifying, going through all those tedious levels is a very huge thing. And coming live here on this platform and presenting a case is a very difficult job, and really hats off to everyone. Congratulations, and it's all your hard work, and I hope that this was a very new experience for everyone. So basically, this is how we do sessions here at Clinicase. So we just wanted to introduce this concept, and that's why we came up with this competition in collaboration with AMSA India, sponsored by Marrow. So any sorts of feedbacks, if you guys have, please put it in the chat box. And now over to you, Akatya. Please add to this and please let us know.
Thank you. Hi, everyone. And as you all know, I am Akatya, and I am the co-founder and the chief executive head at Clinicase. And firstly, I would want to congratulate you to come, for qualifying for this final round after going through those many filters of, preliminary rounds and all of that. I think it's you all have won already. And looking at the entire competition, I think the judges are literally impressed by all the groups which has presented. So congratulations to each and every participant and all the groups. It was very well put up and really great efforts, guys. And I hope that, this entire journey of conducting the quiz and the national level quiz has been really, entertaining and fun. And, we had a great time, doing it for all of y'all. And I hope you all had a great time as well. So yeah, and we hope to see you in our future sessions. We do clinical sessions, case discussions, like how you're presenting. So that might interest the future as well. So let's just keep updating us how you feel about this entire quiz. If you want any suggestions, feedback, they're always welcome. So yeah, thank you. And we're just waiting for the results to come. Till then, best of luck. And yeah, thank you.
If you guys have anything to share with us, then please unmute yourself and please give us some feedback.
Whose concept is this? Clinic case?
So, ma'am, me and Akatya, both of us, we are students of MGM Medical College. And this
Where,
lockdown...
in Kamote or Aurangabad?
Kamote, Navi Mumbai. So, this lockdown inspired us and pushed us to come up with this concept because we were actually missing out on a lot of clinical experience. So
Yes.
we just started like a normal small case study group first in our college, and then we proceeded. So we got a lot of response, good response and good feedback from our batchmates and from students here, like at our own college. So then we thought of why not take it to on a different, on a huge level. Let's take it on a huge platform, because everyone or the students in other states also are facing the same issue due to the pandemic. So why not involve everyone? And basically the basic idea is to get clinical experience by doing these discussions, and to create a very formal yet very casual environment, so that all the doubts and everything gets cleared. Sometimes due to the rush hour in the OPDs, we tend to miss out on very important doubts, and we tend to miss out on very important information, and then we also hesitate to go and ask our doctors. So here, without any pressure of whether there is a time limit or there is rush hour, nothing like that. You can just casually come up and clear your doubts and talk to supervisors. So we do 2 sessions every month. We select 2 clinical cases, and then we also ask our members what clinical subjects they want us to cover. Then accordingly, we invite supervisors from different colleges, and we also have case presenters. So the whole concept is the same. 2 people present the case. There is a supervisor guiding and assessing the whole event and the whole session. So yeah, just in the pandemic.
So this you started in when? In June?
No, ma'am, we started this in the month of August. So
August.
Another commendable thing is to see all you young girls out there. So many girl forces there. So I really enjoyed seeing you all, and very well done, very well organized, and everything was.
Thank you so much.
A wonderful experience.
It was
okay, my young babies are.
It was like a cakewalk, and we had a great time.
Say hello, Viranshu. Come, say hello.
Oh, hi. Hey.
Hello,
You're so cute.
Hello. 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 Just say hello to everyone.
Hello. Firstly, I would like to actually thank Dr. Rupali and Dr. Archana. I know you guys were very busy, and actually everyone, all the participants, Dr. Archana and Dr. Rupali, they are working they're working and they're consulting COVID patients, and they were on call and they were very busy, but still they made it here, and they were not at all hesitant. They were here on this platform. They helped us with the cases. They went through all of the shortlisted cases, and they finalized it. And then this event has actually taken place. So thanks a lot to our judges for actually dedicating time and coming here on the platform and actually conducting this session in a very well mannered. I'm really very happy. And also the organizers, Avantika and Nosheen, they have been amazing. They've not been sleeping. They've been conducting each and every levels, each and every quiz, whether be the screening round, whether be the treasure hunt or the finals. They've been working hard for the past 2 weeks and handling around 1,100 participants. We got 1,100 participants, and after going through all those levels, now we have these 8 teams here for the clinical round. So congratulations to everyone here on board, and Exquisite was possible only because of everyone's effort. Actually, like, like I would like to congratulate everyone. Thank you so
Thank
much.
you so much, guys. Thank you. Okay.
Thank you so much. Thank you. And everyone at Team Clinicase and Team AMSA as well. Both of the teams have, like, put on their staying up till 3, 4 in the night, and completing the tasks, making all the WhatsApp groups, and managing so many participants has not been easy at all. And I think after today, y'all can go get some sleep, and we can celebrate how well this entire competition has gone. So yeah, thank you so much, and kudos to everyone who has made this competition exquisite something so good. Thank you very much, and thank you, Dr. Rapali and Dr. Archana ma'am, for doing this for us. And we are very, very honored to have you both on board. Like, somebody so renowned and so cooperative in this entire journey. Thank you so much once again.
So congratulations to each and every person, and really you are organized very well. I'm really impressed. Very good. Keep it up.
Thank you, ma'am. Thank you. I hope you like the concept and the
Yeah,
theme.
that is why I'm asking you.
A very nice suggestion from ma'am that next time we will keep it more basic. That will help you guys more, because it has to be more clinical. Theoretical part,
Because it's third, first, third, second.
but the clinical part is something which we need to discuss more. I think that was a valid point from ma'am also. And okay,
Yes, yes.
We'll definitely.
Can we leave?
Yeah.
No, ma'am. Any updates regarding the score? Nausheen, Avantika? Avantika, hello?
Shivani, we have shared the winners.
Yeah, Shivani. Hello.
Yes, yes. Hello.
Yeah, Shivani, we have shared the result. Please announce.
Okay, yes. This is really exciting. Okay, so any guesses for the third place? Judges, would you like to guess? Or anyone from the organizing committee? Or should I just like announce it and like not waste any time? I'll go ahead only. Okay, fine. So okay, so okay. Third place goes to group 34, team 3. Guys, please switch on your cameras and come on board, and congratulations.
The names. I'll just say them.
Are they on call?
Yeah. Joyal, Siddharth, and Spurthi.
Yeah.
Yeah.
Guys, please switch on your cameras and please say something.
Can you hear me? Hello?
Yes, we can.
Yeah. Thank you. This was a really, really nice experience for us because I was not expecting the finals to be conducted in such a way. And this was such a new thing and so much more informative, and we could learn about so many cases at once. So thank you so much for organizing this so well.
Congratulations.
Thank you so much.
Okay, moving ahead. For the second place goes to group 8, team 1.
Congratulations, guys.
Guys, please switch on your camera. Group 8.
Himanshu, Swati, Bhargav. I don't think so.
Himanshu, Swati, and Bhargav. Nobody.
Yeah, sorry.
Swati is here.
Yeah, okay.
Hi.
He's also here.
Congratulations, Himanshu.
Yeah, thank you so much.
Once again, congratulations.
Yes, everyone, I would like to let you all know that Himanshu even won yesterday for the pre-clinical round. I think so. He got the second place, right?
Yeah, second place there also and here.
Second place is your lucky number. Second is your lucky number, and that's where you got. So congratulations.
Yeah.
Then finally, let's move on to the first place. First place goes to team 5, group 7.
Woohoo! Congratulations.
Guys, please switch on your camera. Team 5, group 7.
Danish and Arzu.
Yeah.
Danish and Arzu.
Congratulations.
They are on call, right?
Yeah, they are here. Danish, do you want to say something?
Thank you so much. Thank you so much for the exquisite competition as such. All 3 rounds were indeed very good. Yeah.
You guys deserve the first place. Like even I was impressed and I loved the presentation and your confidence. Amazing. The way you answering questions, commendable.
Thank you, Shivani.
Listen, when you
In
get
fact,
a difficult case, the chances of winning are much more. So
yeah.
Be happy when you get a difficult case. Don't get around your residents to get it changed. No.
Yes, absolutely right.
Always have a winning edge. Yeah.
Anyway, congratulations to all winners.
Thank you, ma'am. Thank you so much.
All the best in your future life also. Chalo, keep it up.
Best wishes, everyone.
I would request everyone to just switch on your camera so that we can just have a group picture and then everyone can leave the call. It's got very late. I do understand that, but please let's take a group picture. So all the participants and everyone who's on the call, please switch on your cameras.
And please send us across the.
Yes, ma'am, for sure. Abhilash, are you on call?
No, Abhilash is not on call.
Okay, so who's taking the picture?
You only take.
Okay, I'll take.
You take the picture.
Acha, okay, I'll take. No worries. So Aishwarya, Deepsha, Bhaviksha, please switch on your cameras. Bhargav, Bhavik, Freya, yeah.
Okay, I can remove these specs now.
Okay. Thank you, everyone.
Thank you.
Everyone can leave the call. Thank you for joining
Thank you
us.
so much.
I
Thank
hope you had an amazing time.
Thank you very much.
Thank
Again,
you.
thank you, Archana ma'am. Thank you, Rupali ma'am. Thank you so much.
Yeah. Thank you.
Bye, guys. Good night. Take care. Bye. He's so cute.
Bye. Say bye-bye. Bye-bye, everyone. Bye. Yes. Bye.
We can leave as well, right?
Yeah, just a minute. Yeah, we are removing everyone.
Yeah.